Buongiorno a tutti, come state? Avete preso il caffè? Siamo pronti ad affrontare quest'ultima
Good morning,
giornata di
everyone. I hope you've
conferenza
had a good cup of
sul
coffee
Duchenne.
and are ready to
Allora, sarà
begin
ancora una
the
volta una
final day
giornata
of our
ricca, tanti
conference.
contenuti
We will
e
be
a me
hearing
l'altro
many
compito di ricordarveli
presentations,
tutti, a quanto
and
pare.
I am
Quindi,
going to have the very difficult
informazione
task of
e elenco.
remembering
Allora, questa mattina
all the names.
iniziamo
So
la
we'll
giornata con
begin
una
our
sessione
meeting
dedicata ai
today
progetti
with a
scientifici
session
supportati da
on
Parent Project.
scientific
Come
projects that are
saprete,
supported by Parent
2 anni
Project.
fa
As you
Parent ha
know,
lanciato il bando per il
Parent
supporto alla
Project
ricerca e oggi abbiamo con noi i
organized a tender
vincitori
for research
del
support
bando che ci racconteranno i
activities, and we
risultati che
have
finora
the
siamo
winners, the
raccolto
awardees now, and
molto
they'll tell us
rapidamente.
what's been done
A seguire
in this regard.
invece ci sarà una
Afterwards,
sessione
we'll
ancora una
have
volta tema
a
scienza perché
session,
parleremo delle
another
strategie
scientific
che
session,
affrontano gli difetti
because we'll be speaking
secondari,
about
quindi
strategies
tutte
for
quelle strategie
secondary
che non
defects, the
intervengono sul
strategies,
deficit di
therefore,
distrofina,
that
ma che
aren't
intervengono
related
sui
to a
difetti che
dystrophin
vengono
deficit, but
causati
on
dall'assenza
deficits
della
that
distrofina
are
stessa.
caused by the
Ancora a
absence of
seguire
dystrophin.
avremo una tavola rotonda dedicata
And we'll then
all'accessibilità e
have a
poi in
roundtable discussion
chiusura
on
una
accessibility,
ulteriore
and
tavola
finally
rotonda. Questa
another
volta il
roundtable
tema saranno gli
discussion
aspetti
on
regolatori in Europa, quindi
regulatory
vi consiglio
issues in Europe.
di
So
rimanere con
I
noi
would
fino a quest'ultima
encourage
sessione
you
che
to
sarà
stay
sicuramente molto
till the end of that
interessante.
final session, which I'm sure will
Ovviamente
be very
parallelamente ci sono
interesting.
una serie di altre
And we'll have
attività
some
che potete
parallel activities
seguire
as
e la
well.
prima è il
If you'd
laboratorio
like
di
to choose them,
psicosomatica
we have a
che sta iniziando
psychosomatic
nella sala
workshop that
Merida
is
che è
beginning
al
now in the
piano
Merida
-1,
room,
quindi sarà al piano
which is
-1, non
at
al piano
-1,
-2.
not -2 floor.
C'è
So
anche lo spazio
-1.
registro dalle
And
9
we'll
alle
also
10:30
have from
da
9 to
Microsoft
10:30 the
Smart, quindi qui
registry
di fronte uscendo dalla
space.
sala della
So
plenaria
it
c'è la
is outside
salita
of the
vicino alla
plenary
rampa
hall.
dove
There's a
guardare per
small room
aggiornare
near the ramp
i dati
where
del
you can go to
registro
update
e mi
data
sembra
in the
di aver
registry.
detto tutto
And I
rispetto
believe
ai
I've
contenuti. Un
covered
attimo
uh,
solo.
all
Allora,
the different
altre
parts of
informazioni
our
importanti.
program.
Alle
But we
13
have some
è
additional
prevista la
important
cerimonia
information.
finale
At
di chiusura.
1, we'll have
Sarà
a final
una
closing
cerimonia altrettanto
ceremony. It'll be
bella come quella
a
di apertura,
beautiful
quindi dovete
ceremony
rimanere
similar
qui,
to the
non dovete
opening
andare via, non dovete andare da nessuna
ceremony.
parte.
So I would encourage you
Altra
again to stay
informazione
here, which
fondamentale,
is where we'll
chi
be
di voi ha
holding it.
preso
And
le
then
cuffiette per la
if you've
traduzione simultanea,
picked up
deve
your
assolutamente
headphones for
ricordarsi di
simultaneous
riportare le
interpretation, you must
cuffiette
remember,
anche
please,
perché se
to
non usate le
return
cuffiette non avete il
them, because
documento,
otherwise
quindi
you
sarà
won't get your
fondamentale
document back. So
riaverle
I'm
per
sure
poter
you'll all want
ripartire
to make
in
sure you have
sicurezza.
that so that you
Ma
can
anche se non avete le
leave.
cuffiette, vi invitiamo a andare nella saletta dove
Even
vengono
if you don't
distribuite perché
have
c'è
earphones,
un
you
piccolo
might
dono
like
per
to
voi.
go to the room where they're distributed because there's a small gift for everyone there. And the Director General will let me know if I'm mistaken now when I say that if you have a poster displayed at the exhibition, you must go and pick it up again, because otherwise, who knows where it will end up. Now, I believe I haven't forgotten everything. We should begin because we are slightly behind schedule now. I would ask the speakers from the scientific project session to come up to the stage, one or two at a time, perhaps will do. We'll be following the program schedule. I will introduce them all now, and then they'll know exactly when to come up. We have Francesca Grassi and Maria Egle De Stefano from the La Sapienza University of Rome, and then Dr. Galvani from Padova, and Biliana Lozanoska-Ochser from St. Camillus International University and the La Sapienza University of Rome. So these are grant application projects, which are the major ones. And following those first few presentations, we'll have the fast-track projects on a smaller scale. We have Federica Trucco from the Gaslini Institute in Genova, Dr. Ilias Masmoudi from a university with a very long name that I can't pronounce, from Germany. Happy to have you with us. And then Gabriele Siciliano from the University of Pisa, and Ramignolo and Chiara D'Appunto from the Stella Maris Foundation in Pisa. So Francesca Grassi and Maria Egle De Stefano will be opening this session. Thank you.
Ok, allora buongiorno a tutti. Dunque, questo progetto di ricerca nasce dal nostro interesse comune su quelle che sono le
We'll begin with a discussion on interactions between the skeletal muscle and the central nervous system. We will be focusing in particular on proprioception. In order to move a limb, our brain needs to be able to monitor its position in space at all times, and this happens thanks to proprioception. And through this, we have sensor signals from the skeletal muscle to the spinal cord, and we have motor sensors that control these local movements. But at the same time, these signals occur in the brain where there is a fine coordination, motor coordination. Now, we know that Duchenne patients are slower in moving objects than non-Duchenne people when they close their eyes. So there is proprioception and no visual coordination in this group. In recent times, it was shown in animal models with Duchenne that the neuromuscular spindles that are one of the proprioceptors located in the skeletal muscle are impaired from a functional standpoint and structurally as well. Hence, we wondered, why is there a difference here? So we have the sensory motor circuit at the basis of proprioception. In muscles, we have these neuromuscular spindles, and they send information to the spinal cord, to the medulla, and they control the activity of motor neurons, which are the neurons that send a motor command to muscles. So our assumption is, our hypothesis is, that there might be differences based on multiple points. For example, nerves are like cables that connect muscles, and in Duchenne, they are damaged, they are impaired. They connect them to the spinal medulla. So they might also physically transfer a impairment signal to the nervous system. Now, the difference between sensor neurons and motor neurons is mediated by calcium, but also a substance which is called GABA. And in the brain, in the dystrophic brain, GABA doesn't work very well because there's no dystrophin. And since there's no dystrophin in the spinal medulla, then we wondered how GABA functions in the spinal medulla. So in our project, we studied the functioning of these two different types of neurons that are involved in the sensory motor system. So GABA and the morphological structure of the sensory motor circuit. And we compared MDX mice to, so dystrophic mice, to wild-type mice. In our study, we've studied the function of these sensor neurons in culture. We studied the electrical activity there, and we saw that in dystrophic neurons there is less calcium than in the wild-type neurons, and that means that communication might be less effective. In the meantime, we carried out a study on the sciatic nerve, which is the main sensory motor nerve that connects the spinal cord to the muscles of the lower limbs. And we've shown that inside this nerve, the sciatic nerve, there are structural alterations, biochemical alterations related to nerve conduction, and GABA as well. And we see this in dystrophic mice compared to wild-type mice, and this work has been sent to a scientific journal so that it can be assessed. Inside the spinal medulla, we've seen differences in these motor neurons. In dystrophic animals, the cellular body is much larger, and they are at a greater distance from one another, and these are clear symptoms of cell suffering, distress. And we see this in animals that are 6 to 7 weeks old and 1-year-old animals who've had a progression of the disease. And last but not least, we managed to verify that there is also an impairment of the intraspinal GABAergic system because the protein levels of the GABA synthesis proteins, 65 and 67, and of one of the receptors, GABA-BR1, they are reduced in dystrophic animals. And therefore, we believe that the inhibitory intraspinal system of these motor sensory circuits might be impaired. So coming to my conclusions now, as we imagined, we saw structural impairment and sensory impairments of the system, which will be added to muscle weakness, and that's why there is postural instability, a change in muscular tone, balance deficits as well. So this might make motor problems worse in deambulation. So it is important to understand these issues so that we can hopefully deal with them. I thank you very much for your support for our research and for your cooperation. I thank all our co-workers and Professor Magnaghi from the University of Milan. Thank you very much.
Buongiorno, sono Federico Galvani dell'Università di Siena.
Good morning, my name is Federico Galvani from the University of Siena. This is a preliminary study that you have funded, so hopefully it will be of some interest to you. So it's about a possible treatment of the symptoms of DMD, of course waiting for a possible gene therapy. Now, first of all, this is going to be an antioxidant treatment because there was a side effect due to oxidative stress playing a role in the DMD symptoms. And together with other side effects or secondary effects such as mitochondrial dysfunctions or calcium-related issues as well as inflammations, because of all of that, we have studied a given molecule that is NAC derivate. Actually, it is a well-known antioxidant molecule that is often used, but it has always failed in terms, within the framework of clinical trials, possibly also because this is a product that acts from the outside. Whereas our molecule is quite simple. There's an ethyl group that is attached to it, whereby it becomes soluble. So it may enter the cell, where it is transformed into a common cysteine amino acid, which again will not otherwise on its own enter the cell. So that seemed to be quite important, first of all, because this is the key amino acid for the synthesis of a molecule that is essential for the oxidative stress, glutathione, whereby this stress can be dealt with internally, so to speak. And we have recently considered some retinal disease models where we've seen that there's a key transcriptional factor of the endogenous response to oxidative stress, RNF2, that plays a key role, beside playing another important role, namely one regarding calcium homeostasis, fibrosis, inflammation, and mitochondrial dysfunctions. It also induces the synthesis of all those enzymes that are key to transform cysteine into glutathione. So basically, it's as though we were talking about, both the brick and the mason having to place that brick. We have treated MDX mice for 4 weeks in their acute phase between 6 and 10 weeks of life. So we just placed our NACET in water, good tolerance, no problems, not even for the organs weight. But in any case, we're talking here about a drug that, again, is very well tolerated because NAC as such is already in the market, easy to be synthesized. It is not too expensive. So the same goes for this NACET, NACET. No obvious side effects, plus it improves the muscle contraction of these MDX mice, even when contractions are of an eccentric nature. There's also another effect, namely the number of necrotic fibers is reduced. Now, of course, we need to investigate further, certainly in terms of the possible extension of the treatment through the time when there's a stable degeneration process. So we might want to use it for a longer time. So that's quite promising. Of course, this is only a preclinical, even a preliminary preclinical stage, so to speak. But so far, this has turned out to be quite simple, with a good safety process and not too expensive. So we'll hope for the best in the near future. Thank you.
Good morning, everyone. Thank you, Fernanda, for the introduction. It's a great pleasure to be here with you today and present our results that we obtained over the past year on trained immunity in Duchenne muscular dystrophy. Trained immunity is a type of non-specific memory induced in innate immune cells, such as monocytes, in response to a diverse type of stimuli, microbial, but also stimuli released by damaged tissue. Following initial exposure to stimuli or during the primary response by monocytes, trained immunity is induced at the level of myeloid progenitors in the bone marrow and the spleen that undergo changes in gene expression, changes in metabolic pathways. This is regulated by the mTOR pathway, the master regulator of cell proliferation and metabolism, giving rise to trained monocytes. So, following a secondary exposure to stimuli, and this can happen months after the primary response has resolved and homeostasis has been reinstated, trained monocytes produce increased, enhanced cytokines and pro-inflammatory mediators, and this is the hallmark of trained immunity, where the monocytes, their functional phenotype is enhanced. So this process is beneficial during infection. However, during chronic inflammatory diseases where there is a chronic stimulation of monocytes, induction of trained immunity can be detrimental. So we were interested in studying this process in monocytes in DMD because monocytes are the major immune cell type recruited to dystrophic muscle, where they differentiate in macrophages and contribute to the inflammatory response. They also contribute to the regeneration of muscle fibers. So our aim is to reduce their effect on inflammation while preserving their role in regeneration. To establish whether chronic muscle injury in DMD induces trained immunity in monocytes, we carried out analysis of gene expression in monocytes isolated from dystrophic mice. What we found is that genes involved in trained immunity and associated with trained immunity were significantly upregulated in monocytes from dystrophic mice following stimulation compared to monocytes isolated from healthy mice. Moreover, when we isolate these monocytes from the bone marrow or the spleen of dystrophic mice, they hyperproduce inflammatory mediators after stimulation compared to monocytes from healthy mice. So what this means is that monocytes from dystrophic mice are pre-programmed to produce increased amount of cytokines before they are recruited to dystrophic muscle. So next, we wanted to see whether inhibition of this process will have an effect on dystrophic muscle pathology. For this, we used lipid nanoparticles designed to specifically target monocytes with minimal off-target effects. They are loaded with rapamycin, which is an inhibitor of the mTOR pathway, which, as I mentioned, controls the induction of trained immunity. So dystrophic mice were treated by twice-weekly intravenous injection of the nanoparticles. And after this time, they were sacrificed, and we analyzed the effect on trained immunity and dystrophic muscle pathology. Treatment with the nanoparticles inhibited trained immunity in monocytes as evidenced by a reduction in the production of inflammatory mediators when these monocytes were stimulated in vitro. Moreover, the treatment improved the regeneration of dystrophic muscle as evidenced by an increase in the number of regenerating fibers. And we observed enhanced, improved differentiation of the muscle stem cells, satellite cells in vitro, where they formed bigger myotubes. Fat deposition and fibrous tissue deposition in dystrophic muscle is the major driver of disease progression. And we were very pleased to see that the treatment inhibited fatty tissue deposition in muscle, and this was directly due to inhibition of trained immunity in monocytes, because when the cells responsible for fat deposition in muscle, the fibroadipogenic progenitors, FAPs, were incubated with the inflammatory mediators released by monocytes isolated from treated mice, we saw that we had a significant reduction in FAP differentiation into adipocytes or fat cells. So, in conclusion, chronic muscle injury in dystrophic muscle induces trained immunity, meaning excessive production of inflammatory mediators by monocytes, and inhibition of this process ameliorates muscle pathology by improving regeneration and reducing fat deposition. I would like to acknowledge my PhD student Lorenza Esposito, who performed the experiments and already won several awards for the project, Professor Boucher for hosting us in her laboratory at Sapienza, and all our collaborators. Thank you, and of course Parent Project for financing this project. Thank you.
Buongiorno a tutti, grazie.
Good morning, everyone. Thank you for giving me the opportunity today to speak to you about the preliminary results of this project. And thank you to Parent Project for the invitation and for the funding. My name is Federica Trucco, and I work at the Gaslini Institute in Genova, and I'm also a teacher at the Genova University. Now, Let me tell you about respiratory involvement in dystrophies in general. When we say respiratory failure, we know that this is a common complication that characterizes this disease. Now, we cannot consider this progression to be the same in all of our patients. In fact, we might even say that it differs in all of our patients because it is characterized by multiple variables that are interconnected and, as we've heard, are different from one boy to the next. So, we have variables that are specifically involved in respiratory muscles, so they can be involved. The diaphragm, for example, or the intercostal muscles can be involved to a lesser or greater extent. So we have the characteristics of the disease. We know that they vary from one patient to the next. So there can be scoliosis, there can be a loss of deambulation and weight loss, weight increase, and all the results that we've seen. So it is a progressive chronic condition which might involve the upper respiratory tract, and there might be a cognitive involvement or impairment, and extrinsic characteristics that have to do with therapy, for example. So these variables are all interconnected, and that's why we have so much variability. So considering this variability, we also have outcome measures that are standard, and they are the same for all patients, regardless of age, cognitive status, disease status, and so on. So they commonly involve the measurement of pulmonary volume with spirometry and measurements in patients of their respiratory strength and other respiratory studies during sleep. So we don't have consolidated studies on natural history with regard to the respiratory condition in this disease, and this is very complex, and we don't have disease markers, i.e. biomarkers for respiratory involvement. So the project that I'm speaking about, financed by Parent Project, is related to a more vast activity with other funds coming from Teleton and Wind. And the goal of this project is to try to fill this void, this vacuum, for the first two categories that I mentioned, so assessments and the history of the study of natural history. Now, what are we doing here? First of all, we try to have a better understanding of progression and the characteristics of respiratory progression in Duchenne and in myodystrophies in general, and then the role of genetic clinical factors, therapeutic factors that interact with one another, and try to understand how they contribute in a complementary manner to respiratory progression. And this allows us to assess the variables as well and how we can predict the progression of the disease and respiratory failure by assigning a risk score to each patient. So at the moment, it is a retrospective analysis, but hopefully it will be prospective as well. So we're focusing on the clinical elements, not only the markers of respiratory function in the patients, but genetic variability as well, cognitive variability and motor variability. And we analyze patients who reach certain endpoints, the use of NEVE and respiratory failure. So when they reach a threshold of respiratory failure because of a reduction in pulmonary volume, and that way we can have a risk index for each patient, and this will help us to estimate and stratify the risk of their developing this kind of complication. Now, we're already working on this, and we are going to try to publish, this is our goal, a mask, some sort of mask, and or a software program so that clinicians can include the data which will tell us what kind of risk there is for respiratory failure and what risk there is for certain important complications within a certain period of time after a certain age is reached and after having assigned the score. So we have low, medium, and high risk scores to determine the likelihood of these complications. I would like to take this opportunity to tell you that it's taken about a year to launch the study because of the bureaucracy of the ethical committee. So I would like to make an appeal to try to have a smoother process for this approval. We have the Milan Clinical Center and the Rome Clinical Center at the Gemelli Hospital that are involved, and they're awaiting the opening of the study. We have about 67 patients at the moment, and in the Nemo Clinical Center in Milan, we are analyzing the data in order to create a score and a predictive model for preliminary data, which can then be used on other data once those centers are opened. They're waiting, in fact, to be opened. So this will allow us to assess the risk, and we want clean data on progression, and we want to be able to study the correlation and the contribution of each variable. This is essential, and this is another goal of our study. We want to develop disease models, and we want to identify new outcome measures or measurements, and we want to prepare the terrain for a solid study on biomarkers. These are the members of my group. I wish to thank you, and in particular Professor Sansone from the Nemo Clinical Center in Milan, and Professor Mercuri and Professor Pane from the Clinical Center in Rome, and my group in Genova, and I thank all of you for your attention.
Good morning, everyone. So my name is Ilias, and first of all, I would like to thank the Parent Project for this opportunity and for supporting our work, which is titled SUMUS, Intelligence Navigator for Becker Muscular Dystrophy. So we basically aim to bring together biomechanics, wearable sensing, as well as intelligence, data-driven models with the aim to help patients understand and manage muscle weakness and energy expenditure in their daily life. So with new therapies emerging, there is a need to understand and analyze motor function, as it's a key factor to define the treatment effects in clinical studies. But we know that there are current limitations. So there is a reliance on observer-related performance, which can be subjective and lacks accuracy. There is also an over-reliance on self-reported questionnaires, which can be biased by both memory and perception. They also fail to capture small changes in muscle function, and this is important to accurately track the effects of the studies. And also there is a lack of long-term and real-world data, and this is also important to see how the patients actually develop in the real world. So for our solution, we propose to use sensors from smartwatches and to record data of daily activities, as well as data from certain exercises that were specifically developed for patients with muscular dystrophies. And the idea is to see if we can, from this data, extract meaningful information that can be displayed back to the patients in real time. And this can be done using like some intuitive ways, like in a battery indicator to show like the muscle fatigue during the day. So for this tool to be practical, it needs to be portable, i.e. to work in the home environment. It also needs to be accurate enough as to provide meaningful and important data to the user. It also needs to be fast enough to report the data in real time. So what we have seen from the literature is that many try to directly estimate the energy expenditure directly from the raw IMU data, and this can often ignore the underlying motion, which is important for this task. So for our approach, we propose to do a two-stage estimation. We first of all try to predict the underlying motion in the first stage. Then in the second stage, combine that with other data such as the height, weight, and maybe the heart rate, and then estimate the energy expenditure. So for our first proof of design experiment, we used an upper body musculoskeletal model and generated synthetic IMU data as well as motion data such as the joint angles of the upper body, and we also have the true metabolic cost. Then we trained different AI models, and from the results we found that this first stage of estimating the motion variables was able to give us more accurate predictions of the energy expenditure. And in other work, we collected data from a pilot study of 3 healthy participants and 3 patients. And from the results, we were able to correctly identify the exercise that were performed in the Sumus app. And we also found out that the IMU signals can hold some information about the presence of muscle weakness. For the next steps, we aim to collect synchronized laboratory measurements using a multimodal sensor setup. And from that, we can validate our proposed two-stage approach. And if successful, our approach will allow us to have continuous monitoring of upper limb function. It would also allow us to have sensitive endpoints for clinical studies and allow for the early detection of functional decline. And thank you very much for your attention.
Buongiorno, ci spostiamo.
Good morning. We can now move on to Tuscany. The title of the project is When I Grow Up, and this is part of the projects on muscular diseases, which there has been great focus on. In other words, to focus on the transition period from the age of adolescence to adult age in many neuromuscular diseases. The approach to this kind of problem must acknowledge that there are many actors involved, and the projects must be able to monitor all of the effects and all of the spillovers on a more integrated process. So the Duchenne Parent Project has made an important contribution, and we were one of the first at national level to have an inter-company decision, the center in Pisa, for example. And then there was an important role played by 2 centers, Mayor in Florence, Michele Sacchini, in fact, is here, and Elena Procopio, and Stella Maris in Pisa with Roberta Battini and Guja Astrea. In our center, we have Giulia Ricci and Francesca Torri, who are the colleagues primarily involved in this. This is a process that has a regional PDTA. Our PISA center is the coordination center, in fact, for the regional network of rare diseases, for neuromuscular diseases in particular, the European network, and these are the data that we've managed to collect up to now, also thanks to the Duchenne Parent Project support. And this is for some of the characteristics of the Duchenne and Becker population. You see that 77 patients here in the chart in the past 3 years joined the project, where there is a very close cooperation between the neurologist, pediatrician, or the neurologist for the adult, and unexpectedly, the number of Becker patients is much higher than Duchenne. There are multiple reasons to explain this, but the most important point down here is that most of the patients are already part of the project, and they followed the different referral phases and the therapy or support protocol. We need these data in order to extrapolate epidemiological data. You see here that in the Tuscany region, we have 55 patients with Duchenne dystrophy stratified by age in the different areas or provinces of the region of Tuscany. And you can also see that in this case, the prevalence data is corresponds to Duchenne muscular dystrophy. We can plan, therefore, the healthcare that might be needed, and then natural history. You see this graph with some important endpoints of the natural history of the Duchenne dystrophy, and on the right-hand side we see some unusual, so-called unusual phenotypes, but we must be able and ready to assess those today, even if they are unusual. So this is the model for transition from pediatric to adult care in Tuscany. Not only Tuscany, it's being done in other regions as well. We have the InGene 2.0 project. We're working on this for the digitization of this transition process. And here we pool all sorts of information, clinical, diagnostic, and therapeutic data. We pool all the data in order to generate platforms which can be used side by side with the clinical daily activity, the diagnosis, the follow-up, data collection, and the effects of therapy and treatment, and any change in the natural history of the disease. So I thank Parent Project again for having funded the project, and I thank you all for your attention. Good morning. We would like to present the comics project. This was created because we needed a rehabilitation process with regard to cognitive and linguistic capabilities of Duchenne and Becker patients. We will be presenting this project. Other colleagues were not able to come. I'm Stella Maris. Now, there can be motor difficulties as well as cognitive and linguistic difficulties in patients with muscular dystrophy. Even if they recover their linguistic capabilities, there might still be some difficulties in the complex part of the language. In other words, the inferential and pragmatic capabilities. This is what we call them, and this is the ability to understand an implicit message or to understand irony and communication initiative. So these are abilities or capabilities that are very, very important and help people to feel comfortable when they are with others. These capabilities are closely linked to the emotional and social dimension of persons, and this is how we had the idea for the project. If communication and linguistic dimension is so linked to the emotional and social dimension, then we have to work on the former because it will have an impact perhaps on the latter. So the goal was to work on these abilities, these capabilities, and we assessed 12 youngsters between the ages of 14 to 25. 7 participated in the project. We created groups, study groups. We will present the results for 3 participants who completed the project. And for the others, the project is still ongoing. So there were 12 meetings, 2 hours each, and the mode was chosen by the family on the basis of their needs, so whether physically present, online, or mixed, hybrid. Now, at the end of the process, we assessed the youth with ad hoc tests that haven't yet been validated, and in particular, the inferential capabilities were assessed through tests that include a comprehension test of sayings, of popular and common sayings, and paradoxical situations as well. And the dialogical and communication capabilities were assessed through a questionnaire given to parents, and they answered questions on the different aspects of communication. It was a very fun protocol for these youth. We proposed different activities, cartoons, role-playing, and table games, card games, such as Dixit, and we simulated some social situations, and these youngsters were always directly involved. They learned to understand irony, emotions, the tone used to speak, and the pre and post treatment comparison shows an interesting fact. The younger youth who had more difficulties at the beginning improved more than the others with regard to the inference tests, and even the older youth improved, but it wasn't as marked as an improvement as we saw with the younger boy. So when you intervene early, the results are quite effective. Even for communication and dialogical abilities, we saw an improvement for the older as well as the younger subjects. Now, at the end, we issued an evaluation questionnaire, and we saw that there was great appreciation for the project. We saw some youth who participated initially, but who then didn't continue participating in the project. We asked why, and they said because they weren't interested in the activities that were proposed. And in addition, most of these youth told us that it wasn't important for them to work on emotion and on feeling comfortable with others. And therefore, we wondered, was it a real lack of interest? Do they think they don't need it, or are they just not aware enough of this issue? So this is a question that is still open-ended and that we will try to find an answer for. At the end of the project, we created some end products to take into account the work done. With one group, we made a video where they were doing role-playing, and with another group, we are creating some comics, and with others, we've asked for a written narration that you see on the slide, a written story. Now, in conclusion, these patients with muscular dystrophy have some difficulties with these kinds of competences, with these skills, and yet we will continue, and treatment for the moment is still pharmacological. But we think it is important to work on these skills to try to improve communication skills and awareness, emotional awareness, because we see this as a protection factor. And this is what the youth say. As we see in the slide, they talk about being aware of their difficulties and not being able to express their opinions at all times. So we think that we need to work on this further. The project that we are presenting is a pilot project, so it's just a starting point. There are some limits and some open-ended questions still that we have to work on, but it is a starting point, and we think it is important to invest in this area. Thank you for your attention. Thank you very much to everyone for your work on these projects. It is important for us to fund this kind of research. It's part of our mission, and hopefully we will soon be able to have a new tender. But in order to do that, we need everybody's support. Now, very briefly, we have a service announcement. We have a lost and found item, a USB pen, and an earring. So if you've lost these, the USB memory stick or an earring, please come up here to get it. Now we'll talk about secondary deficits. These are strategies which are focusing on the absence of dystrophin in cells. We have Luca, Bello, and Riccardo Masson, who will speak to us about this. They are approaching the stage, and they will soon be presenting their information. As you've noticed, I'm sure, we have a novel element in our conference, and that is that in the scientific sessions we have families as well. So we had a sister and a brother and a mother and a father participating. This has been a successful experiment, and this is a way of reducing the distance between science and families, and this is what we try to do with our work in our scientific department. So I'm very happy to be able to ask Daniela Argilli, one of our mothers, to come up to the stage, and she will be introducing this session with a story about her experience.
Buongiorno a tutti.
Good morning, everyone. As we've heard from Ilaria, my name is Daniela, and I am the mother of two adolescents, Anna, who is 15, and Lorenzo, who is almost 13 years old. Lorenzo has Duchenne's dystrophy, and we learned about this when he was nearly 2 years old. By chance, he had some blood tests. The CPK value was high, which is what we often see, and only a month and a half after the blood tests did we have a diagnosis for him. So, as we always say, we fortunately didn't have to go through a period of uncertainty. Despite this gloomy diagnosis, there was no uncertainty, so we knew for a fact that that's what it was. Now, maybe this disease has a name which is difficult to pronounce, and yet the doctors provided us with all the necessary information, and they also were hopeful. They said that compared to years ago, for this disease, there are many, many research projects. There were at the time, in fact, and when Lorenzo would turn 5, he probably could participate in some of these projects. This is what they told us then. Now, some years went by with a bit of uncertainty. Lorenzo was still very small. He couldn't really cooperate. And during the checkups, the clinicians and the physical therapists were preparing him so that he might know what kinds of activities and tests he would be involved in a trial. The North Star walking test, for example, we started with that. He was still very young, and we didn't really have a full understanding of this overall protocol. After all, he was still quite well. He was okay, and we wondered what our reaction might be once he was called to participate in the trial. And finally, the call came, and he was nearly 7 at the time. The doctors proposed 2 different approaches. for my son. We were very happy. We had some doubts because we were going to have to decide in a very short period of time which one to choose, either to choose nothing or to choose one of the two. So the clinicians and the association as well helped us because we needed to realize what it would mean for him to be on a trial, one or the other. And there would be nurses, maybe for blood tests to be done at home, and what it would mean at school for his relations with other classmates, and what it would mean for the family for him to be on the trial. So we discussed this with the association, with the clinicians, and we finally came to a decision. Lorenzo's trial was to begin on the 9th of March of 2020. That is when there was a lockdown in Italy because of the COVID pandemic. So we were upset, of course, at first by this, but fortunately, just a few months later, it was possible for the trial to start in any case. So it's been 6 years now, nearly. Lorenzo has been part of this experiment all this time, and I can say that we're happy, notwithstanding the medical results that we won't be able to understand fully yet. In any case, over time, we realized that Lorenzo managed to find some sort of balance in this situation, and we also found our balance. And he, had to deal with some side effects. He had to overcome those, and it was important for us to share with him the importance of what he was doing. His efforts were important for him, of course, but for the other youth and children that might somehow receive this treatment in the future. So the trial process taught us many things about Duchenne. It taught us how to deal with uncertainties, because we were making projections about the future, and we needed to manage that situation. We had to find a balance between our expectations for a better future and a present, which was quite difficult. So we had to keep seeking this equilibrium, this unstable balance. It was difficult, but it's the only thing we can possibly do. It is important to have an alliance, including clinicians and associations that help families to understand how to move on, how to take these steps. We think that this is a very important strategy, according to our experience. So this is what happened to us, and I will now hand over to the clinicians, Luca Bello from the University of Pavia, and Riccardo Masson or actually Padova. Luca is from Padova, and Riccardo Masson from the Carlo Bestia Institute in Milan. So they will give us an overview of therapeutic approaches which aim at correcting these secondary deficits. So thank you, and I'm sorry for making a mistake. Luca Bello from the University of Padova, Riccardo Masson from the Bestia Institute Milan.
Grazie mille per la presentazione.
Thank you very much. Thanks for your introduction. I'm going to hold the microphone so that I can more easily use my slides. So we're talking about secondary defects. So the idea is to use some drugs so as to reduce the damage downstream, the lack of dystrophy in the muscle. I have not included my disclosures, but let me tell you that I do cooperate with the companies that are responsible for the programs that I'm going to deal with today. This is a complicated slide. We owe it to Annemiek, I'm afraid, because this is her slide. Anyway, this is about what happens when there's a dystrophin gene issue and the lack of muscle strength. This is what happens in the muscle, and all of them can actually account for therapeutical targets. Indeed, some specific drug classes have been developed accordingly, for mitochondrial dysfunction, calcium-related issues. You've heard about that already. So let me try try and make it simple. This is a somewhat simpler chart, actually. You know, there's no dystrophin. The dystrophin complex is basically disrupted, so there's no more membrane, and we get more damage in the muscle fibers. Chronic inflammation arises, fibrosis, neurodegeneration of muscular fibers, muscle weakness eventually. So this shows the different mechanisms that I'm going to deal with. So let me start with the first one, that is muscular contraction due to the myosin ATPase. That is the real, the real engine here, and that can also account for a therapeutic target. Cevazentam is the one drug that deals with this particular problem. So the muscle is weak because we are trying to reduce contraction. This is an in vitro test. There's a dystrophic mouse muscle that is made to contract on an in vitro basis, and when the drug is injected, apparently there's a reduced damage. So by reducing the contraction of the muscle, a vulnerable muscle may actually get less damaged, of course, through a properly modulated dosage. Now, cevazentam is very often used in BMD, and I would particularly like to stress that when we talk about secondary defects, it's easier to both talk about DMD and BMD. Yesterday, some very good questions were asked about gene therapy, for example, about whether it could be used for BMD, and actually the answer was I don't know. We don't know. There are several differences indeed between the two diseases. However, when we talk about secondary therapies, be sure that they can both concern BMD and DMD. So this is a phase 1 small-sized study and two somewhat larger ones on 40 patients, including adults, and then there's an even larger one, hopefully a phase 3 study, the Grand Canyon study, on 170 patients. Here more diseases and more exercises are included. So what about the markers here? Well, if the aim is the muscle damage, we need to measure all the substances that are released by the damaged muscle, including CPK, of course, and other more specific ones that are indeed the best markers for us, such as TNNI2. Here you see that the markers seem to be reduced, so there's a target engagement, as they say. So the drug has actually, reached its target. But does this also entail clinical benefits? Well, apparently there's a more stable North Star test that BMD patients have borrowed from the DMD ones. So here you see there's an obvious decrease by, say, 4 points. Well, I'm sure you know better than I do that controlled data from the outside, if you wish, are to be taken with a grain of salt. So this is a larger study, the Canyon larger study. So at the end of the placebo observation, the data are not statistically significant. But the aim here was not to show clinical efficacy. This is actually a smaller sized study. So apparently, however, those who were on placebo get stable once, they are given the drug. But again, data to be taken with a grain of salt. And this is another study with a specific statistical design. Data will be published next year. 175 patients have been enrolled. Now, as for DMD, we have data from 2 different studies. We've really tried to use the optimal control dosage. This is a drug that binds to the muscle remarkably, and the quantity of muscle changes from DMD to BMD patients. So we've really tried to make the dosage as best as possible, because we really wanted to detect the right point where the drug protects the muscle from the damage without weakening it too much. So you see the placebo phase is quite short, and then there's an extension study, an extension part too. Now, with algorithms based on clinical data, we envisaged our possible expectations. Okay, it has to do with speculation, so please do take it with a grain of salt too. So possible worsening of North Star and gait parameters were envisaged, but stabilization seemed to arise too. And this is the Fox study. It is of quite an innovative nature. It's about those patients who have already been on gene therapy, and we know that leaves room for some clinical needs that must be met through new standards of care. So that was quite an interesting study. Okay, having said that, let me move forward to another topic that has to do with the glucocorticoids. For the last 40 years, they have been a milestone in DMD therapy or DMD treatment. Vamorolone, let me start with this one. Sorry about some misprints, says the speaker. Anyway, vamorolone is supposed to keep its benefits face to adverse events. There's still less activation within the DNA of those glucocorticoid-sensitive motifs, and that are therefore responsible for some relevant side effects. Within the heart, some benefits might actually occur. The mineralocorticoid antagonist plays a role, so this is a drug that may mimic the action of previous drugs used to treat cardiomyopathy. Metabolism is different, especially at different, at some tissues, which might explain the reduction in side effects. So, vamorolone, again, at the center you see an important registration study. Today, some extension studies are being carried out. I can certainly give you some data about that. And you know that we did get some FDA approval, for example, back in December 2023, of some of these drugs. But I'm sure this will be a topic for our discussion. Vision DMD is key to vamorolone approval. It is the one study with the major evidence regarding this. So you see here the dosage, 6 milligrams per kilo, the standard dose by now. And we have two controls, a placebo and a prednisone. And interestingly enough, we did see more efficacy as compared to the placebo group. So even in the short term, vamorolone is as beneficial as the previous corticosteroids. And here, please look at what is green and purple in this chart. Apparently, the clinical effects seem to overlap. The objective here, however, is to improve side effects. So the strengths are about the bone health. As for prednisone markers, we did not get the same results with vamorolone. And if patients, were put on vamorolone, those, at a later stage, those markers seem to do better, and other values seem to be, to go back to normal. And these are data rather regarding, behavioral problems such as, anger, sleep disorders, and so on and so forth. So now some new data about the long-term observational studies. So patients come from different controlled studies. They are, gathered together within this study, whereby they they are seen for even over 3 years. Of course, an external control is of paramount importance, as I'm sure you know. So we get it from different studies, including the one that has compared prednisone, deflazacort, and again prednisone, but with a different pathology. So the data were compared with those from a Canadian group that is indeed very active in DMD. So, by comparing with some statistical methods through the so-called survival or even ambulation curves, it is obvious that more and more patients we get some patients still using the wheelchair and other ones that are still ambulating. Vamorolone at different dosages seems to have led to overlapping results if compared to other corticosteroids. As for age, untreated patients with cortisone still present in the historical synergy cohort. There's very few of them right now because they're all on standards of care, at least in this part of the world. They lose ambulation very early, but with vamorolone and other corticosteroid, once again, there's an overlapping. Patients only treated with the deflazacort, which is very often used here in Italy, even more often than prednisone, because it seems to, actually give better effects. Once again, the comparison is not that easy, but these patients were also seen as they were growing up, and we have an adjusted value in terms of height, and if we compare this to average, we'll see this result, but with classical glucocorticoids, there's a loss in percentiles when it comes to height. So with vamorolone, apparently things are better from this viewpoint. So these boys have kept their ambulation, have got taller as compared to other boys treated with classical corticosteroids. We used to think that if height was not increasing, ambulation could be kept longer, but apparently that is not the case, as we see from this data. But again, there's room for discussion here. And then weight gain and Cushingoid aspects, they can all stay with vamorolone, but otherwise we see again sort of an overlapping with vamorolone as compared to classical corticosteroids. Now, incidence of fractures as seen through an X-ray of the spine, there's a lower incidence here, with vamorolone, which seems to confirm what we had already thought by considering the relevant biomarkers. These are data about cataract. Here results are more or less the same. So very quickly, yesterday you heard about a BMD animal model whereby we can study vamorolone for BMD2, and these are the two American colleagues responsible for that. Primary and secondary therapies here seem to overlap because in the dystrophy muscle, inflammation seems to reduce the dystrophin quantity. So if we improve inflammation, we might even have more dystrophin, obviously only in BMD patients. And actually, in Pittsburgh and in Padua, a BMD study was carried out. It was a 3-month study, so a very short one, of course. Data may be interesting, but they will probably be published soon. And now the floor goes to Riccardo. Thank you.
Grazie Luca e buongiorno a tutti.
Thank you, Luca. Good morning, everyone. Let me begin with this diagram, which we've been using as a guide. Unlike what happens in the physiology of muscular damage, where there is a pro-inflammatory phase and regeneration, an anti-inflammatory stage, and differentiation of cells, especially muscle cells, with muscular dystrophy, we have chronic damage, which creates a bit of confusion in these processes, and this results in impairments linked to chronic inflammation and a hyperactivation of a class of enzymes which are called deacetylase histone. And this is what will help us to speak about givinostat. Now, you can see in this chart what happens physiologically after cell damage. The histones, which are proteins around which the DNA wraps itself under acetylation, allow for the exposure of DNA, which can be subscribed and give rise to proteins and factors that are involved in the damage repair mechanism. They are FAPS cells, FAP. We've heard about them, the progenitor cells of fibroadenocytes, and they might not differentiate and produce fibrosis and adipose substitution, or inhibit or actually create a muscular regeneration process, and therefore the satellite cells are transformed into myoblasts and then muscle cells. What happens when there's a hyperactivation? Well, the DNA is packaged around the histones, so the mechanism cannot occur, and this is where givinostat comes into the picture. It inhibits the mechanism and it allows for a physiological response. So on the one hand, it avoids fibrosis and excessive inflammatory response, and on the other hand, it helps muscular regeneration. This is the process that resulted in the approval of givinostat in 2025 by the European Community, as you know, and the European Commission, and the EPIDIS is a phase 3 study which demonstrated the effectiveness of givinostat, and this allows us now to test it. I won't describe the study, it's already been covered, and it was published in 2024. So quickly, it is a phase 3 study which lasts 18 months, and it included 179 patients. Its primary endpoint was the 4 steps here. You see that the overall included population was subdivided into 2 groups. The target population, where we assess the effectiveness of the drug. There were children in this group with this index here, a fraction, the lean muscular mass fraction of the muscle, which was 5 to 30%, and we identified, therefore, a population that was sufficiently strong, but where there was, in any case, a risk of the progression of the disease. So very briefly, this is the outcome of the 4 steps. We see a difference here with 2 different forms of expression, but they say the same thing. There's a difference between the control group and the treated children group of 1.78 seconds. So it is significant, and it is in favor of givinostat, of course. In practice, it is important to understand what happens with regard to potential side effects after the treatment. These are the main effects that have been observed in the study, and according to the real-world experience, this has been approved. So there is a potential gastrointestinal problem, diarrhea, being the first effect, which appears a few weeks after the beginning of the treatment, and it is generally resolved. It is usually mild. We also have a platelet, low platelet count. 32% of the patients had this, and this is what we saw in the laboratory. In other words, we didn't see any bleeding incidents because of a low platelet count. It is just dose dependent. So the reduction in the dose of the drug in 3 or 4 weeks' time results in the reduction of this problem, and therefore the platelet count goes back up. And for hypertriglyceridemia, we see this increase in triglycerides after the decrease in the platelet count. We saw the peak 200 days after the beginning of treatment, and it is also a dose-dependent effect. So by reducing givinostat doses in a short period of time, you can regulate the triglycerides. And in these cases, they were mostly mild changes. This is the dosage scheme recommended for the drug. You see that we have an initial recommended dosage, which is based on the weight of the child. And then we have two possible dose reductions, which are linked to the factors that we've just covered. In other words, should there be a platelet count which is lower than 150,000 or triglyceride count above 300 milligrams per deciliter, then and even more than 4 incidents of diarrhea, you can reduce the dosage of the drug. The dosage is indicated here. It depends on the weight class, as I said. And then there is a second reduction before having to stop the drug altogether if necessary. And here we have the dosage reduction scheme, which is weight-related, and the onset of these events, and which are therefore manageable. This is the monitoring scheme, which has been envisaged on the basis of what we've just said. So we have an initial blood test, a complete blood test, which has to be done before beginning the drug administration, and the platelets are monitored at first every 2 weeks, and then up until month 2, and then month 3 and 6 and onwards. And the triglycerides, well, it is a bit longer here because we have a different curve for the reduction of platelets and an increase in triglycerides. So basically, we repeat them every 3 months at first and then every 6 months. We must also assess other elements such as electrolytes, potassium. So hypokalemia has to be corrected if it occurs, and we also have to assess the presence of concomitant therapies, especially the ones that can prolong the QTC. Now, this is the cardiological monitoring. It's another area. Givinostat, well, the data, in any case, preclinical data show that it can increase the QTC when the dosage is very high. During the study, the EPIDIS study, the dosages for human subjects didn't show an elongation of the QTC. In any case, it is important to be cautious in high-risk patients for ventricular arrhythmia or patients who have factors that might result in the increase in QT, either a basic underlying pathology or concomitant factors, i.e. drug administration or other. And there are drug classes that can prolong QT, the QT wave, and this is something that has to be assessed on an individual basis and according to the drug that is used. With this population, we would focus on antipsychotic drugs because with risperidone or others in children who have behavioral disorders, then, or I mean, even antibiotics, for example, but it would depend how long they've been taking it. The antipsychotics would be aripiprazole or risperidone. Now, hypokalemia is very important, as I said, because this might be triggered by factors such as diarrhea or other concomitant factors. And an increase in QTC above 500 milliseconds or a variation of the baseline greater than 60 are criteria which would require us stopping the drug altogether. This is a recommendation that was produced by Italian clinicians with regard to cardiological monitoring. You see that we've made a distinction between children, in 3 groups of risks in children. The low risk, children with a QTC less than 450 and no family history or concomitant medications that could prolong the QT wave. And the intermediate risk group is when we either have a family history or concomitant drugs. And the high risk group is when we have a QT which is below 500 but above 450, and where there might be other associated factors. So this would change our monitoring protocol. In the first case, with the low-risk group, the ECG would be repeated after 3, 6, and 10 months, and then we would have a traditional follow-up for children in these conditions. So examination after 6 months. The cardiological examination can take place every 6 months, and this is a standard protocol. And here is when we have an additional ECG, and we have cardiological monitoring, which is more intense, and there would be an examination before the beginning of treatment. And finally, in the high-risk group, we have to carefully assess the beginning, the initial administration of the drug, and the initial cardiological examination would require a Holter and ECG with 12 leads, and then the different monitoring schemes that we saw with the other risk classes. Of course, there might be events that would occur in the meantime, and the child might change from one risk class to another. So if we have incidents such as the introduction of a drug that increases the QT wave, or other pathologies occurring, or a change in the baseline ECG, then we could change the risk class and therefore the monitoring protocol. Now, the drug is a homogeneous oral suspension. You have to shake it before administration, and it is administered twice a day to the children. We have no particular precautions that have to be taken with regard to preservation, and once you open the bottle, you can use it only for 60 days. Here we have a syringe to dose the drug. 3 days ago, they released the Italian Drug Agency communique. They can reimburse now this drug, and we are waiting to see the publication on the official gazette of this decision. The important point being that it is considered to be innovative, so there will be an AIFA registry as with all innovative drugs, and there will at some point be uniform access. It won't be managed by the region, but at a central level, a centralized level. Now, let me go back to this overall scheme that we've been using for my two final remarks very quickly on two other approaches that we can use. We'll first discuss this drug, which is called CAP 1002 Diramyocel. This is a treatment for which we don't have any direct experience in Italy. It is an approach that was developed and tested in the United States. And they use cardiosphere-derived cells, so come from myocardiocytes that then undergo a protocol, a culture protocol, and a treatment protocol, and they're infused IV. The idea here is that they can release exosomes which contain factors which boost, or actually there is a modulation of inflammation and an antifibrotic activity in muscle cells. This is what we would have. So microRNA and products that belong to this group. This is a phase 2 study that's called HOPE-3, HOPE-2, and then HOPE-3. This hasn't yet been published in the peer review journals, but the results were published by the company at the end of 2025, and we see that the treatment is effective in the group of patients treated. There were about 100 subjects in the group, so they were treated compared to the control group, and there was the endpoint, the primary endpoint of the study, PUL, P-U-L, and then the left ventricular fraction. This is a targeted study, in fact, for children who do not ambulate, even though in this group 3 study there were some patients who did ambulate. This is a communique of the company that produces this drug, and it describes the effectiveness in reducing the progression of the disease. There are also long-term data for phase 1 and phase 2 trials, and the safety profile is based on protection of allergic reactions after IV administration. So this might be complementary to other therapies that have direct action on dystrophy. You see, it is not a therapy. It is not a therapy with histamine cells, but they are cardiocyte-derived cells that are placed in culture and therefore are reprogrammed. The final remark has to do with the bone problems. You know that the Roche Shield study had assessed the possibility to use satralizumab in order to reduce the effect of interleukin-6 in the muscle, so the pro-inflammatory cytokine factor, as well as in the bone, where it can differentiate the osteoclasts and therefore induce an increased bone reabsorption. So direct osteoporosis or mediated. So satralizumab is a monoclonal antibody drug, and it binds the receptor for interleukin-6, and it's been studied in other neuroinflammatory diseases as well. And in this study, there were to be 2 weeks. It would be a 2-week study with a primary endpoint after 1 year on bone density. And I'm speaking in the past tense because unfortunately in February they announced that they would be stopping the program. Roche announced this because of difficulties with enrollment in phase 3 of the drug, of this drug protocol. And one of the secondary endpoints would be the outcome after 6 months to see whether there was inhibition of the action of the antibody on the receptor of IL-6, to see whether there would be an effect, in fact, on the reduction of osteoporosis linked to these reabsorption mechanisms. So we'll see what data comes out of this interim analysis at some point. Thank you very much for your attention. So I've completed the overview of these drugs. Thank you.
Grazie a entrambi per queste presentazioni estremamente.
Thank you very much. Those were very clear presentations. We don't have much time for questions, but we also have representatives from some companies in the hall. Well, of course, they won't be able to answer to direct questions because this is a drug that has just been approved. Therefore, they can't really provide any answers there. Any questions from the floor? Was anybody raising their hand?
Pronto.
I would just like to say that as for cardiospheres, one should use some, cautionary approach. I have seen no evidence of an immunological privilege in these studies, no immunosuppressors. So either we reconsider it all, either we reconsider what we've learned for the past 50 years, or we might want to wonder something. Would you like to comment? Thank you for your comment. Actually, I'm afraid Capricorn was not with us, the company responsible for the development of this product. They could have provided you with a clear-cut answer, but I'm afraid they are not here. But we can, of course, let them know. Right. Any other questions? There's a question here. A Deflon patient right now on Divinostat, can he move to vamorolone therapy? Yes, there are no contraindications. Divinostat was developed in association with corticosteroids, and vamorolone is indeed within the corticosteroid class. Therefore, it is quite likely, that such associations will be embraced. So givinostat will be included, I believe, sooner or later. And as far as we know, there are no data about reimbursement. But as for how this should be done, well, of course, dosages will play a key role because sometimes they must be lowered because of the corticosteroid tapering therapy, and apparently the dosage of vamorolone should be a full dosage. In older boys, this might lead to more effects. However, we can't really see whether that is due to vamorolone or deflazacort or their dosages. I believe we'll have to ask internal doctors and other clinicians to come into play and give us their advice, because vamorolone may have a different action on the adrenal gland, for example, especially at the beginning of the treatment. So we need to be cautious, but the answer is yes, although with some caution. Thank you. Another question here. Can we be on givinostat if one has already been on gene therapy? Has this been the case anywhere in Italy? And can we envisage vamorolone and givinostat for those who have been on gene therapy? Now, in clinical terms, the answer is yes. There's no reason why this should not be done. So such associations seem to be perfectly possible. However, we're still waiting for some data. We are still actually waiting for some data about, mainly from the IFA card that will certainly tell us more. So we're talking here about the Drug Approval Association here in Italy. So, any other questions? Now, apparently givinostat was approved for DMD, but not for BMD, right? Is this, an absolute stance or not? Luca, you've actually dealt with the givinostat therapy in BMD patients. Yes, indeed, years ago, a study was mainly carried out in Milan. It did not actually lead to a real registration, but right now approval is only for DMD, actually. So we can't really prescribe this drug for BMD, but why not? There may be room for approval for BMD too, through a regular process, of course. Antonio, I believe you have asked. Okay, I hope my answer is clear. Well, I suppose that if a drug is effective in DMD, it should be effective in BMD too. Apparently, there have been histological improvements too, so why shouldn't that lead to a BMD approval, maybe further to a phase 3? Well, I share your opinion there. There is room for, hopefully including it also in BMD lists. So we're certainly going to ask this question.
I have 3 questions. One I would like to repeat from yesterday's day. Is connected with possibility to using givinostat by women. Second is possibility to if we have some outcomes from clinical trials on disabled or on not working people, not working boys. And third one, my son is participating in clinical trials of givinostat 8 years. And I would like to know, my son is not walking now, and I would like to know if Fidel Pharmaco take care about these boys, if, for example, it will be not possible to be in a reimbursement program in country like Poland, for example.
Allora, rispondo in italiano.
I'll answer in Italian. So, to your first question, can girls be treated, actually? Well, as far as I know, there have been no studies with a female portion of the population with givinostat. Of course, it's all about DMD without any specifications about sex, but symptomatic female patients usually do not have a typical DMD picture. So I believe this will have to be considered on a customized basis. So it will depend on the clinical picture of the relevant female picture. As for your second question about non-ambulating patients, there is a trial. Ulysses is its name. It is now ongoing. It is about non-ambulating patients who, of course, also have different inclusion criteria, upper limbs, regarding upper limbs, for example. So if this study's inclusion criteria are met, well, then the non-ambulating patients can definitely be more properly considered. Your third question was about reimbursement for non-ambulating patients, considering that your son has already been on that therapy for quite some time. I'm afraid I can't answer this question because this is a question to be asked to the company when the time comes, and we'll certainly do that. I'm afraid there's no more time for other questions, so thank you very much. I'd like to thank Luca, Bello, and Riccardo Massorica, as well as Daniela. Now the floor goes to Giuseppe Giardina for our last round table. The title is What About Accessibility?
Okay. Buongiorno.
Good morning, everyone. As you can see from the title of our panel discussion, together we will try to talk about accessibility. When we speak of accessibility, we don't only mean eliminating architectural barriers, but quality of life, relationships, and psychological and emotional needs and well-being. In fact, our objective is to try to explore the issues, problems with regard to this subject and what resources we have available. Now, we live in spaces, we move, we meet others, but this is all never neutral because these spaces can facilitate or hinder accessibility. So I think an important fact is that it isn't possible for everyone to be autonomous and to fully participate in daily activities. It is thanks to the presence of our speakers today that we will try to gain a better understanding of this. We will hear firsthand what these difficulties could be, how they've tried to overcome them, and we will also hear from experts who will help us to understand even more. So I will now introduce our speakers, and then we can begin our session. We have a lawyer, Director, Alessandro Gerardi from the Luca Association, Fabio Amanti, External Relations, Institutional Relations Manager, Parent Project. We have Flavio Lita, who is the creator of the project Zero Barriers, Power for All, and Mirko Natili, Fundraising and Communications Manager. Before jumping into this, we have to explain what we mean by accessibility and what tools exist today to make this a reality. So let me begin by handing the floor over to Alessandro. I will begin with a question, and perhaps he can explain some of these points to us. So, Alessandro, when we speak about accessibility, we often only think about eliminating architectural barriers. But from a regulatory and cultural perspective, what does it mean to build accessibility? And why are tools like PBBA and the elimination of individual barriers so crucial to the quality of life of people? How can we prioritize interventions, and are there legal or simply technical parameters for all this? Well, thank you very much, Giuseppe. I would like to begin by thanking Duchenne Parent Project for their invitation. It's a great pleasure for me to be here with you today. So what does it mean to build accessibility? I will try to be brief. So building accessibility means to design something for everyone. It means to design environments and services that can be accessible and used by the largest possible number of people, regardless of their physical conditions, you see. So it means to think, building accessibility means that in the design phase already, we have to remember that no one must be excluded. So this is a project philosophy, which is called Design for All, and it is more topical than ever today. So this design philosophy aims at creating spaces, products, and services that can be used by people, regardless of their physical conditions, as I said, without there being a need for specific projects that would perhaps create ghettos rather than inclusive environments. It would isolate people in different groups. So a contemporary approach that doesn't seek to build so-called usability alternatives. I don't like this term, usability alternatives, but it was an argument that perhaps was valid in the past when it was thought that people with different needs, this is what we call them, people with different needs, should experience in alternative ways an urban collective context or setting. So they would create a beach for disabled persons or ad hoc service for disabled services, but this caused isolation, segregation, and not inclusion. So the new philosophy, the new Design for All philosophy, has practical repercussions. What are they? Well, the main one is that today, in the design phase, when we want to build a public work or a public project, one must realize that that work must have tactile floor for people with visual disabilities, or there must be an access ramp for people who have mobility tools. And then for people who have sight impairments, all the signs must be readable for them. So in the design phase, we have to think of how a child or an elderly person or somebody with a motor disability or sensor disability would move about in this public space, in a square, in a post office, or a library. The Design for All philosophy is different compared to the past. So we must take into account the digital world as well. So we need new solutions for digital accessibility. So we need somebody who has a sensory disability to use digital services and therefore to purchase autonomously on the web. E-commerce solutions, therefore, and we need an inclusive education to foster culture. We need to think about new apps that provide real-time information to people on the accessibility of public spaces even. So these are just some examples, but they show that when design is thought for all, is conceived for all, then it makes daily living easier without creating any ghettos or exclusive environments or environments that can only be used by certain categories of people. This new cultural movement and design philosophy in the past 20 years, more or less, has helped us to place at the center of public attention the theme of universal accessibility. It is more and more topical, fortunately, in all areas of life: sports, culture, web services, mobility, work, education. So in everyday living, we always speak about universal accessibility today because finally we understand that accessibility is a fundamental human right. The UN Convention on Persons with Disabilities says this as well. So we've acknowledged this new approach, and there was in our Constitutional Court a ruling years ago that states that accessibility is an essential quality for public spaces and buildings and even private buildings. It's a fundamental element. Without accessibility, there is no chance for everybody to use those spaces and places. We have case law of the trial courts and the appellate courts, and it says that accessibility is a fundamental human right because it is the precondition, accessibility in the broad sense of the term, the broadest sense. It is a precondition, a requirement, a prerequisite without which people with disabilities cannot exercise all their other fundamental rights. If there is no accessibility, there is no right to studying, right to work, right to sports. If there is not an accessible environment and if there is no transport accessible to them, then all these other fundamental rights are jeopardized. So our courts and our Constitutional Court as well tell us that it is important to remove, it is essential to remove all these obstacles and barriers that exist between people and the exercising of their fundamental rights. And this isn't done only to preserve the dignity of those people, but to respect their well-being and their psychological and physical health, because they need to feel comfortable. If they live in an urban setting which is not accessible and where they cannot exercise their fundamental rights, then people have to lead a segregated life inside their homes. They cannot go out. They cannot have projects, life projects. They cannot be independent. They always have to depend on others for any kind of assistance, even for the minor activities that they have to perform daily. And this will have a negative impact on their health, both physical and psychological health, because it leads to anxiety and stress. So there would be a worsening of their health conditions overall. Now, before concluding, let me say this. You asked me about the architectural barrier elimination plans. Well, the PEBA plan. We have an important normative tool in our municipalities, and all public administrations should have this, and those are the plans for the elimination of architectural barriers. If we could have these approved plans, we call them PBA plans, PEBA, it would improve the quality of living of the disabled persons and overall of people, because these plans are a dynamic planning tool. And the centralized and decentralized public administrations can map these architectural and sensory perceptual barriers, and at the same time they can plan the projects that will be needed in order to remove the barriers. So every year they can allocate funds so as to implement the projects, and that way the urban and collective environment would be more accessible to all. You were asking me how the prioritization is done for these kinds of projects. Well, we don't have any legal criteria, just technical criteria, I would say. So the public official and the city employee, the architect, have to draw up these barrier elimination plans, and they need to consider multi-criteria, multiple factors. So it's not that the municipality can overnight make a city completely accessible and eliminate all the barriers that are out there, because there would be no resources to do this. But it is important to have planning for this upstream. So they can take into account the complexity of a certain barrier or the position, the strategic position of that barrier. And we, of course, we have to prioritize projects on public buildings and health facilities and schools, for example, and then other barriers. And then we have to consider the technical complexities in eliminating the barriers themselves, because we have to make sure that there's compatibility between the cost and the available funds when technical solutions are decided. So these architectural barriers elimination plans require analysis, assessment, planning, strategic planning, and monitoring, and then concrete projects that are funded by the municipality. This is a complex activity, but without this, without the different steps, we will continue to have cities that are full of architectural barriers that will simply create places of exclusion and segregation. Thank you very much, Alessandro, for your overview. This will help us to understand what we speak about when we use the term accessibility. It isn't only a good practice, it is a right which is guaranteed and which must be protected and enforced. And in order to do this, we have instruments, and they can be implemented so that this can become a reality. We know, however, that these important instruments run into complex situations out there in the community. So now I will hand over to Fabio, who will tell us a bit what it means about what it means to run into these complexities out in the field, in the community. So Fabio, here's my question. You worked on a plan of this kind in Lazio, in one of the municipalities. What were the difficulties you ran into when you tried to implement the plan on the ground?
Innanzitutto parliamo di un comune.
So we're talking here about a town in this region, the region of Lazio. The first barrier was simply to get to know about that, which was by chance. It was through the member of another association reporting about the use of this plan against architectural barriers. So it just came, with word of mouth, and we decided to enroll to the participation paper. So first of all, awareness. That is indeed, issue number one. And secondly, when we met for the first time, we heard the people from the municipality say that they had been the winner of a European project, a European donor, and they could build a given, they could work on a given part of the area. So we replied to that, since there were many association representatives that were present there, including an association, local association of mothers. So, there was a remarkable degree of, involvement. But then, to that, we replied by realizing that, for example, there's no dialogue between the different offices responsible for different things. So the point was to try and put all the different competences together and hopefully get them to agree, of course, on the same issues. And then there's the problem of money. Funds are often limited, as Alessandro has said, and actually during these meetings regarding the building of just 4 roads in the small town of Albano, we heard them say that once the limit had been reached, there was no way we could go beyond. But, there was no time for actually going through the data and possibly planning further interventions maybe in the future. So what was written, what was about some parts of this road building, which did not include, for example, the presence of a ramp or a special stair. So in other words, disabled people could just, cross the road, but then there's no way whereby he or she can move around because no special aids have been envisaged for that. And this is indeed an extremely problematic issue because this plan to eliminate architectural barriers is nothing but bureaucracy, quite frankly. It has nothing to do with improving these people's quality, local people's quality of life. So accessibility was mainly viewed as a formal requirement. Yes, indeed. As I said before, the zebra lines, they were there on one side, but not on the other side of the supposed ramp. And then, as Alessandro said, of course, there's the whole lot of legal issues whereby disabled people's rights are simply not claimed enough. But there's another problem. I mean, I think of my own son. Whenever he goes out, he can't really say, look, I want to go to that particular road because I want to see, I don't know whether there are shops there. That is absolutely impossible because a motor disabled person must plan his or her journey first, knowing that there are places they can go to and other places they can't go to, which of course also has some psychological consequences. So it is indeed only about bureaucracy. That's it. It's only that. For example, ramps. Well, here, for example, there's obviously not. I mean, the staircase here does not meet the legal requirements. But anyway, we're often told that sometimes actually stairs or staircases may have been built, but we simply don't know much about that. And, the take-home message is for a disabled person, you're not welcome here. We don't want you here. And then money. Everything seems to be too expensive, but the point is that there's no planning. As Alessandro said, I need to map all needs, and then on a yearly basis, I must allocate the different funds for them to be used at a local level. But that is simply missing. I mean, there's no will. There's no inclusive will. As the person responsible for institutional affairs within the association, is there anything you would like to tell the whole community? Well, first of all, as an association, we need to become better aware of those town municipalities that are considering the utilization of this plan against architectural barriers. So try and be a sort of a watchdog to sense whether something is going that way, or something may have been done, but not enough. And if there are problems, please let us know. After Flavio, Mirko will take the floor, and he will be talking about a project that we have in mind. We need to have data. The association must have data with which to go to see the different institutions. We've been talking about scientific data so far. Yesterday, we even talked about management data, but here we're talking about about accessibility data. If we really want to have a say and talk to the people from the different public administrations in a credible way, well, we must learn from our community about the problems that they come to terms with. Because without those data, it's going to be hard for us. We really don't know what to say, simply enough. Thank you very much, Fabio. Thank you. Actually, the situation seems to be quite complex when it comes to accessibility here in Italy, accessibility that must be viewed from a technical viewpoint, but also from the viewpoint of public awareness. There's a gap between what is in the law and what is actually implemented locally. By the way, let me go back to Alessandro for a minute. I have a question for you, Alessandro. Why is it that so far so few municipalities in Italy have used this plan? Thank you, Giuseppe.
La testimonianza, quello che
Thank you very much. Well, further to what Fabio has said, we may say that we know clearly enough that public administration offices in Italy work quite poorly, I'm afraid. Now, this plan against architectural barriers is envisaged within the framework of a 1986 act, whereby all, regional, national, regional, local administrations shall approve of this plan within 1 year, from the coming into force of the law. So within 1987, theoretical, all public administration in Italy should have had a plan against architectural barriers. 40 years have gone, and the Luca Coscioni Association has carried out a survey in different municipalities. So as of today, there is no Italian region where such plan has been approved. As for municipal administrations, only 36 of municipalities, from mid to large size have approved it, but only 36% of them. So there's some 8,000 municipalities in Italy. Well, only 20 to 25% of them, as of today, have actually approved of that plan. So we're lagging behind because some 80% of Italian municipalities have not approved of that plan yet. Now, why is that? Well, mainly, as Fabio has said, because as we learn from the municipality administrations, is a lack of money. There are no funds enough. There may be other priorities. So once again, it's an alibi, quite frankly, and it's quite ridiculous. It's hilarious because 40 years have gone. Do we really have to believe a municipality administration that says that in 40 years they couldn't find the money? No, thank you. We feel like they are really laughing at us. But then, as the law goes, this plan approval shall not be subordinated to funding, because we're talking about fundamental human rights. So they can't really tell us we don't have the money. Well, you'll have to find the money to make your town accessible. You don't have the money to build, a school building or allow your young people to have an education? You couldn't possibly say so. And there's another reason behind that, namely there's no education in the public administration officials. They are very obsolete, if you wish, in considering whatever pertains to architectural barriers. They are simply not competent enough. They know nothing about universal accessibility or design for all, which means that this plan, if approved and implemented, is often, done badly. It's actually the wrong one. And then this plan may just be approved out of a merely formal requirement. Well, we have actually seen this. Just a two-page report was enough for the approval to take place, maybe a quick mapping. But I mean, once again, it's laughable because this plan, in order to be actually effective, must comply with the regional guidelines. And secondly, it must be approved not by the municipality government, but by the council. And then it must concern the whole, town area, not for roads, as Fabio said, so that, say, the periphery is left out. Some disabled people might live out there, and they shouldn't be ruled out. And lastly, this plan must apply to all kinds of disabilities. So barriers are of different natures, and they shall all have to be faced up to, because that is what universal accessibility is about. Because otherwise this is a plan that does not comply with the law, and unfortunately the different associations involved are not aware of this. However, that plan that has been approved and which is not actually a pleba should be the object of a legal battle with other courts, because this is a plan that is not, that the single public administration's discretion is supposed to decide upon. The plan must be approved and implemented within given terms and in compliance with the regional law. Thank you.
Grazie, Alessandro.
Thank you, Alessandro. And in fact, you're helping us understand why there is so much distance between a law envisaging certain things and the fact that this cannot be actually achieved and enforced. Now, it isn't only an abstract issue, because it impacts the lives of people who want to be autonomous and who want their own project, life project. So let us now shift our focus and hear from someone who can tell us about what it means to live in a place which isn't designed to be accessible. I will hand over to Flavio, and let me begin with a question. You have acquired experience at university, and we're not only talking about spaces, but the right to plan your own future. What obstacles have you run into, and how has this impacted your experience with the university? Now, good morning. My name is Flavio Alita, and I'm 23 years old. I live in Potenza, and I'm attending the IT department at university. I'm registered, but I'm not allowed to study. University means autonomy, socialization, inclusion. It's a world that projects you into society and into work, but this hasn't happened to me. Now, to begin the university for me meant to live in a world that was in no way inclusive. Autonomy and socialization are denied. And to deny all this to someone means a discrimination, in addition to being an obstacle for my growth and my own future. Over time, I've run into multiple obstacles that have had a major impact on me. These events have been negative, but I've managed to look at the positive side of this. In 2021, I began university, and at the time, I was very happy to be able to attend. But my enthusiasm was dampened on the very first day. When I went to the classroom, there was no station, no seat for me to be able to follow the lesson. And my father took action to resolve the problem, and he spoke to the university multiple times. And finally, in 3 days' time, there was a desk which was appropriate for me, and I could sit there and follow the lessons. But that was only a partial solution, because I was able to study, but the desk was far from the other students, and therefore I couldn't socialize with them, and it was too close to the blackboard. So for multiple hours, I had to sit in the wrong position, and that was creating physical damage. Now, for this reason, I was able to follow my classes remotely, so no socialization, but in any case, some of the difficulties had been solved. I couldn't even freely move about autonomously in the university because of the fire doors. There were many fire doors that I couldn't open on my own, and then the elevator buttons that were way too high for me, so I would have needed somebody accompanying me to move about and even to go to the bathroom, and I never had a person to assist me, even though I asked for this. And in any case, it was just been a bit of assistance, not everything I needed. So my parents had to leave their work to come and help me. So I started following the classes remotely, but there were still problems. The internet connection would fail, and the video camera, the webcam, or the microphone sometimes don't work. So I would have to skip hours and hours of classes. Despite these difficulties, I managed to pass all the exams except for one, the programming exam, which necessarily had to require my presence, physical presence, and I needed to use the university terminal for exercises, and I was able to do those exercises only a few times. So I had to repeat the test multiple times, the exam, but I couldn't pass it. So at the end of 2022, I decided to stop my studies because the situation was unbearable for me. So that is when something happened inside me. It was a spark which actually came only at the end of 2023, when some friends asked me to write articles denouncing these facts on a social site, a social media site. So I said, okay, I decided to write the first article in January 2024, and I described a very serious situation at university, and I decided to send the university to some political representatives of the municipality and the region, and in particular the president of the 4th committee of the council of the Basilicata region, who decided to do something, and he summoned a hearing in February of 2024 on that issue. And during the hearing, I illustrated all the problems at university and the laws that weren't enforced, but no reply. The university was entirely absent from this exercise, and that is why a second hearing was summoned. And this time, the university representatives came, but just to justify their failures, and without proposing new solutions, and without truly understanding the meaning of my denunciation. They just interpreted it as attack. Everybody has the right to study at university, and in their own regulations, they talk about measures to allow disabled persons to study. And an accessible university would certainly be even more attractive, but this is something they've never really understood. At the end of the hearing, it was decided that the region would try to come up with the funds to eliminate these barriers, and they presented the quote for the work to be done. In March of 2024, the region found the funds to eliminate the barriers, and it approved a motion on this, but the university did nothing. So the situation was suspended for some months. There would be regional elections, And then Senator Versace finally began looking into the matter. At the end of 2024, I told her about the situation at a meeting in Potenza, and a few months later, she came to a meeting with the rector of the university. At that meeting, we took stock of the situation, and we agreed that while the senator would consider the tutor problem, the university would submit a project for barrier elimination. Now, the fire doors are now open, and they've installed some of the chairs, the mechanical chairs on the staircases, but nothing else has been done. So the objective of having a completely accessible university is still very remote, but something is being done, slowly but surely. And whenever I can, I go back to this issue. I keep fighting, but the university makes things difficult for me. They seem to be resenting me because of what I do. Thank you.
Certamente quello che ci racconti.
Well, what you're telling us is indeed complex and very difficult. We understand how difficult it must have been for you to experience this. In any case, you've been encouraged to take action, even in your region. So it was a difficulty, but you found a personal motivation to do something, and therefore you've involved the local authorities in your municipalities. So what has this done for you, and are you also still feeling ignored? Well, the difficulties that I've encountered in the past and now have encouraged me to do more to have the rights of disabled persons respected. I managed to turn rage into strength. I see difficulties now as opportunities, and I am engaged in my region with projects and initiatives. Now, while the university issue was being dealt with, I did many other things. For example, for the rights of the disabled, of course, and I became therefore an activist. Now, in March of 2024, I had the idea for a project, Zero Barriers, Power to All, so as to make the city of Potenza more accessible. And the project had to do with the commercial activities in the city, but the overall objective was to make all these public and private spaces accessible, and to provide access to public or private spaces might mean to not be able to socialize. And it is a form of discrimination, of course, and it becomes even more serious when we realize that a place is inaccessible, but nothing is done in order to solve that problem. So in the project, we're trying to raise awareness among the shop owners on the importance of the elimination of mental and architectural barriers. We're asking these merchants to make their shops accessible by setting a portable ramp so that everyone can access. That doesn't cost much. It's a simple solution, but it is important. It has great social value, and these merchants therefore receive a logo which states that they are accessible, and they also are then mentioned on the official site of the municipality of Potenza. So this was launched. There was great enthusiasm, widespread participation, and then there was a contest for the creation of the logo that was open to all the citizens. And then there was a voting procedure on social media, and the 5 most voted places were considered by the technical jury, and the chosen logo was presented in May to all citizens. And it was first delivered in August of 2024 in the Historical Center, where there were many architectural barriers in the presence of the institutions, of the authorities, and that is when they began delivering the logo to businesses already accessible and those becoming accessible. So the project began with the best of intentions and with high expectations, but to date I'm not satisfied with how it's progressing. In fact, the goals haven't yet been achieved entirely, but only because of the mental barriers and the insensitivity of merchants. Over time, I've launched several initiatives within the project in order to raise awareness among merchants, institutions, and the public about disability issues, but they haven't taken root yet. And in addition to interviews and newspaper articles, I've produced some flyers about the project to distribute to businesses in the historic center. to no avail. So in July 2025, I decided to organize another major event to raise awareness in the community, what I call the wheelchair walk. The aim of the initiative was to allow institutions and citizens to experience firsthand the difficulties faced by people with disabilities every day by having them navigate the streets of the city centre in wheelchairs. During this walk, which was well attended by the institutions, many critical issues were highlighted. It seemed that something had shifted, changed in the institution's conscience. But after 6 months, nothing changed, and the critical issues that were highlighted remained unchanged. As part of the project, I also launched another initiative in cooperation with the Beer Festival. This was held in August of 2025, and I was a spokesperson, a testimonial. I wanted to raise awareness and somehow challenge the merchants in the historic centre. We organized a free lottery, and the winner received a free platform, a free ramp for access. Together with a group of people who helped me, we went from business to business to hand out the free ticket. And some even refused it. Other merchants, however, apparently already knew about the project, and many of them were already working on setting up the platform. Now, several months have passed since then, but nobody has done so. Again, I bring up the issue whenever I can. But the road is a long and winding one. This journey that I have undertaken has given me quite a lot, but at times I still feel that I'm stuck and that no one's listening. I've tried everything to raise awareness among merchants and institutions, but nothing has changed so far, and each time I keep hitting a rubber wall. Unfortunately, people aren't listened to. Everyone pretends to be interested, but then they turn a blind eye because it's not their problem. Now, they're aware of the issues, and yet nothing is done to solve them. So it's even worse because this indifference is voluntary. It's a voluntary indifference. In the city's historic centre, there are about 100 businesses, almost all inaccessible. Only 5 of them have built ramps to date. I'm very disappointed by this situation, I must say, but my character and my strength of spirit continues to give me courage every day to not give up and to keep fighting, because they cannot possibly win. After all, these are rights that we're talking about, and they must be respected. I know, however, that I'm doing the right thing, because to have won an award for this project and to have been chosen to speak here today means I believe that I'm doing the right thing. So this fight is fought for me and for those who are in my same situation, and to ensure that those who come in the future will never have to experience these difficulties again. I hope that I can be seen as an example for others. To live in these conditions is far from easy, and sometimes it can be discouraging, but to fight for one's rights is always worth it, even when the road ahead is full of obstacles.
Grazie mille Flavio, questi applausi te li meriti tutti perché...
Thank you, Flavio. You deserve the applause because your account conveys a very powerful message. You can have individual difficulties, and yet you can try to do something about it, to change the situation, to find the necessary resources to change the collective conscience. We must determine whether there are instruments and tools that can assist you, for example, in enforcing these rights. So let me go back to Alessandro with this question now. Are there effective tools that disabled persons and associations can use in order to demand that the laws are enforced and to ask for the elimination of barriers? Yes, these instruments exist. I was impressed indeed by Flavio's testimonial, because it shows that a person can do quite a lot. Someone who is showing resolve and tenacity and managed to achieve many, many results. Maybe not everything that he would like to do, but quite a bit has been done. In Italy, we approved in 2006 a European directive that introduced in our system a special anti-discrimination protection. It is a special civil process in court which is accessed in order to fight discrimination. Now, the story that Fabio has told us is a clear case of discrimination. Our case law clearly states that when there's an architectural barrier that doesn't allow me to access a public space, that is a form of discrimination outright. We think of the typical example of discrimination, the desire, the will. So you put a sign outside of your store basically saying that a disabled person cannot enter. Well, this is something that we don't see, fortunately, today. But the problem is indirect discrimination, because our lawmaker has said quite clearly that regardless of the will to discriminate, even if there is no will to discriminate, but if a public administration or a private merchant omits to do something or has a certain conduct, and therefore they don't want to directly discriminate, but de facto, indirectly, they are discriminating against a disabled person because they are at a disadvantage compared to other citizens. So that conduct is considered to be a discrimination. So the example of architectural barriers is clear. The municipality doesn't eliminate the barrier, perhaps not because the mayor doesn't want somebody to go there, but because they don't have the funds, they don't have the projects, they don't have the plan to do that. However, the discrimination is indirect in any case, because by omitting to do that, to remove the barrier, by omitting to remove it, then someone who with a disability is at a disadvantage compared to other citizens, objectively speaking. So we have to be clear on this. We're talking about fundamental human rights. And the public administration and private individuals cannot say that there aren't enough resources. This is the external excuse. They can't say, no, I don't have a ramp because I don't have the money for it. Sorry, but that is a fundamental human right, and I have the right to go to that office, to that square, to that shop. We have public offices today where the municipal offices are that are not accessible. There are health facilities that are not accessible. This is a scandal, and you cannot keep justifying it, saying that there aren't any resources. So we do have a tool today. Law 66 of 2006 has introduced a special civil process, a civil proceeding, and it is faster than an ordinary proceeding. And why is it important? Because in the past, a disabled person who couldn't access a public space could at least hope to receive some sort of compensation for the damage, but the problem wasn't eliminated. I can't go to the square, and I'm asking the city to pay me damages, but then I still couldn't go there, and the judge could not force the municipality to build that ramp because that was an administrative activity. It was up to the municipality to decide when they had the money to do that. Instead, with this law, this has changed. A civil court can convict the public administration or a private individual if it's a shop. The judge can convict them and ask them to pay damages because the damage is there. And the court can even order the public administration, the region or the private individual, or to the company managing transport, for example, the trains and the subways. The judge can order the person responsible for that discrimination to build the necessary ramp or whatever it is. So 2, 3 months, 8 months' time, however long it takes. It depends on what it is, a barrier to be eliminated or a ramp to be set up. So this is an important concrete tool that we have now, this law. So a disabled person on his own can use this tool in order to force a large municipality to do certain things. Here in Rome, for example, we have a pedestrian bridge which links the Ostia Antica stop to one of the largest archaeological parks of Europe, the Ostia Antica Park, and that pedestrian overpass has steps to go up and down. There were people foreigners who came to Rome to visit the park, and they would have to get off the stop at Ostia Antica, but they had to stay under the overpass because they couldn't go to the other side. They either had to take a taxi or 2 buses or whatever, and instead they could have taken the overpass in just 5 minutes to cross over, like all other citizens do. But they haven't solved this. There were petitions submitted, mayors who were saying, okay, I'll do it now, but in order to install an elevator, we need the money. We don't have the money. So in the end, there was an association that lodged an appeal, or they filed a complaint, actually, in court, and they asked the Court of Rome to order the municipality to do the work. So there was a decision, a ruling, and the ruling ordered the city of Rome to install 2 elevators in 2 points along the overpass so that that would be accessible. The work is ongoing now. It will be completed by January. So you see, with this instrument, with this complaint that was filed, they were able to solve a problem that had been there for years and years. So these are judicial tools that can be resorted to. And today it is possible to access beaches, certain areas of the subway, cinemas, sports events, cultural events. So you see, the instrument exists. You have to be aware that it does. Not all associations know about it. In any case, you can overcome the problem, stop the discrimination through these procedures. Thank you, Alessandro.
Thank you very much. So both individuals and associations may use these instruments, which is very good news. We have now learned that these are instruments that can be implemented. So, we've also learned so far that individual experiences may be very relevant to public awareness, but the same applies to the actual implementation of such, individual experiences that go through a collective approach. So now Mirko will be telling you about a campaign that has a specific mission. So please tell us more about this campaign. You have already collected some data. Can you tell us what they imply? Thank you, Giuseppe. Now, this is a campaign that started from the previously asked questions. I mean, what about accessibility in Italy today? Where do we stand? Are there any criticalities? Where and why? Any particular experiences that may be helpful to us? So, as we've said so far, accessibility is of paramount importance, and this also includes inclusive campaign. A non-accessible town does not allow all its citizens to benefit from its public spaces, whereas we are all entitled to engage in public activities on our own, out of autonomy. So these were questions that we felt should be answered. Therefore, we have envisaged a questionnaire including some direct questions about these topics, and that was basically the first step of our campaign. Who started is one step at a time. So it's a questionnaire about feelings, personal perceptions rather than anything else, but it can certainly allow us at least to find an answer in the way people perceive what the civil society offers them. So a mapping of all accessibility conditions in Italy was then embraced. So what about the data? The data are awful, quite frankly. If you If you go through the different regions, you'll certainly find different data, but we are definitely below average here. Some questions were, of course, the questions were about accessibility, and the answer was supposed to be provided through a mark from 0 to 10. Well, the average number in Italy is 3. But there is a difference, a remarkable difference among regions. So 3 regions in northern Italy score between 4 and 5. Then in central Italy, we have approximately a number orbiting around, a figure orbiting around 2. So there's a remarkable difference indeed. Thank you. Well, indeed, that's all about how multifaceted Italy can be. But can these data become a practical tool for us to talk to the institutions? And is there a specific approach that Parent Project has embraced? Well, here is the real challenge for us now. The picture we seem to have taken so far is quite negative, but we want to make it positive. So our next step is to hopefully make both the questionnaire and the map. We want to keep both of them updated, therefore making them possible to be used in a shared way by all those involved. This can allow us to improve our knowledge about the issue. And thanks to this, the other instruments will become more effective, hence the relevance of a report that we want to publish every year, so as to have a sort of a list of historical data, if you wish, that may also allow us to record the positive changes or what has not gone to the right direction, and for our campaign to hopefully become truly practical and tangible, we have thought of some specific instruments, picking up on what Alessandra said. First of all, raising, awareness-raising campaigns. We also want to involve mass media as much as possible when it comes to accessibility. We want this to be the case for individuals as well as the whole society. And then we would also like to be actively involved at a local level. So we're going to get in touch with those public administrations that have scored, the worst. And there's another instrument that we have derived, if you wish, from the campaign. Actually, in some cases, local institutions have got in touch with us about our campaign and about their scoring. They wanted to know where they stood. So they got in touch with us. So generally speaking, I may add that this campaign that, as I said, goes with a mapping of Italian areas regarding accessibility. Well, this campaign is a great instrument, one that may truly serve the purpose. So, of course, this may lead to some improvement. So we, as Flavio has said, we have decided that some recognition should be conceived for those town municipalities that rank best. So let me conclude by asking you all to fill in the questionnaire that you'll see on your tables, and please share this questionnaire as much as you can. Here is the questionnaire. Christina and Guy are showing it to you. Through, of course, this, you can participate in our campaign, and this will certainly be a very first step forward. Thank you.
Grazie molte.
Thank you, Mirko. Thank you for telling us about this communication campaign. Once again, it seems like Italy is quite a multifaceted area. Now, we as an association know that there's still a long way to go, but apparently we now know where to go. It seems like we have a direction, and each of us can contribute to that, as we've learned from the people who have been kind enough to share their experiences with us. So I wish to thank the speakers, warmly thank them, and let us all try and play the actual sentinels of our society. Thank you.
Stiamo?
Allora, grazie a tutti gli oratori di questa
Thank you. I'd like to thank all the speakers of this very interesting round table. And now we'll move on to our final round table. It is indeed a pleasure for me to ask the speakers of this round table to come to the podium. This is going to be, as I said, our final session. As you've heard from what I told you yesterday, the regulatory aspects have become more and more relevant to our approach. We have even devoted, some parts of our conferences to this, since patients must be made aware of such regulatory pathways. So it is a pleasure for me to give the floor to Susanna. After her, we are going to listen to Ms. Cerreta, who up until a few months ago was within EMA, so she knows what the European Agency for Drugs regulatory pathway is all about. So, Susanna, you have the floor.
Così? Where do you want to? You want to be here? Devi mettere parte. Salve a tutti. Salve a tutti, quindi io oggi parlo in italiano.
Good morning, everybody. Thank you, Fernanda. Thank you, Parent Project, for including this roundtable on the regulatory pathways in your conference. I don't know, quite frankly, what Fernanda has said about me. I was not really listening to her. But I'd like to say that I am the founder of a Blue Companion, namely a partner of Parent Project for patients' registers or registries. We know how relevant data are for building up any regulatory action. It is my pleasure today to introduce you to Francesca Cerreta, who's going to lead us through the way EMA works. She worked 29 years for EMA, within EMA, and mainly she worked within the scientific advice group, whose experts give advice on the clinical trials design, whether it's from academia or companies. And Francesca has also worked in different coordination groups, which also included FDA as well as other national agencies, mainly for the last part of the drug approval process, namely when the way of namely as for reimbursement actions. You know that right now 27 countries are EU member states. That has been the case since the UK has left. So within the framework of these 27 EU member states, EMA, of course, prevails. However, when it comes to the so-called health technology assessment, the final assessment, well, then national agencies come into play. That is IFA for Italy, AIFA. So Francesca will be leading us through the pathway, mainly regarding orphan drugs. And then Fabio will have the floor. You've heard him before. You know that he's responsible for institutional affairs within Parent Project, and he is part of this, newborn regulatory group. And then Pat Furlong will take the floor. Pat is the founder of the sister association of Parent Project and Muscular Dystrophy. She will be telling us about what patients can do in the US. And then there's Ramona. Ramona works. Ramona Belfiore Ocean is the executive director of a critical path spin-off. It's a U.S. organization that works for enhancing dialogue among stakeholders. So companies on the one hand, patients on the other hand, and regulatory agencies on the other hand again. So without any further ado, Francesca, you have the floor.
Grazie a Parent Project per avermi invitato qui. Spero di poter spiegare.
Thank you to Parent Project for having invited me to talk about the approval of pharmaceuticals in the European Union, and I won't be too lengthy because too many details might be boring, and that way I will make sure that you have plenty of time for the final discussion, which I think is very important. You can always read the presentation afterwards if you have access to these slides. I've retired now, so what I will tell you is on my personal behalf. I don't represent the EMA, the European Medicines Agency position. EMA is in Amsterdam. It was founded in 1995 after being in England for many years. Its main role is to provide a scientific evaluation, supervision, and monitoring, so evaluation of data before approval of drugs and the assessment of data once the medicine is used in the real world on the market. And there are three elements: the quality in the production of the pharmaceutical, so safety, efficacy, and quality. So the structure of EMA has become more and more complex. The main committees, setting aside the working groups, are 7. There are 5 for human drugs. Actually, the most important is the CHMP, the Committee for Human Pharmaceuticals. The second is for Drug Surveillance Committee on the safety of drugs, and the others are important for Duchenne, the Committee for Advanced Therapies, Gene and Cell Therapy, and then COMP, the Committee for Orphan Drugs, Orphan Status and Significant Benefit. If we have to demonstrate the benefit of certain therapies. And the last one is the Pediatric Committee, which is important for Duchenne, again, because many studies involve these pediatric study groups. So why do I say in being revised? The word here is in revision, being revised. This complex has become more and more complex over the years. So it is important to speed up the process for the approval of a drug. At the moment, the European Commission has proposed some legislation in order to facilitate the process, so to streamline it somehow, and I'll say a few words about this towards the end of my presentation. On orphan drugs, these are the two main European regulations. For the designation criteria, the committee, how we assess, and what incentives there are for orphan drugs, such as market exclusivity. The second regulation contains implementation criteria of the law of the first regulation. For example, if someone is producing a similar drug, how do you determine which one is clinically superior? So they need to know that to decide whether or not to approve the drug. What incentives do they have for orphan drugs? Well, reduce or exempt payment for the EMA evaluation, and this is important when there are small companies or universities developing the drug, because we have many small businesses that deal with the initial phases of development of these pharmaceuticals. Then we have protocol assistance. These are scientific opinions on the development plans. So EMA provides an opinion on the adequacy of the plan so as to have sufficient data for the approval of the drug. This is when clinical studies, of course, have a positive outcome, but the design of the clinical study is what is being assessed. For orphan drugs, they grant 10 years of market exclusiveness, +2 if it's a pediatric drug. These are being revised because the law has tried to balance speed with market protections, and maybe these numbers might change. Then there are protections against copies, because you invest in the development of orphan drugs, and a company needs to be protected, making sure that they have some sort of economic return on the investment that they're making in the research. And there are 3 exceptions when the sponsor provides consent and when there isn't enough of the drug, or if there is a clinical superiority demonstrated compared to the drug that is currently available. Now, the CHMP, as I said, is the main committee. It deals with human medicines. They assess the dossier and they appoint 2 people, a rapporteur and a co-rapporteur, who produce an independent evaluation in the first 80 days of what the company says, the pharmaceutical company or the developers, and this is presented to the committee, and after the presentation the members can either object or have additional questions. Maybe they have some areas of expertise that are a bit different, and therefore they can add to this evaluation somehow. There are many other expert groups that can contribute, and in those expert groups we often have patients and carers, especially if there are meetings, ad hoc meetings, during which to discuss this drug. PRIME is an initiative that I coordinated for 5 years at EMA, and it has to do with innovative medicines. We try to follow the development and appoint a rapporteur much earlier, and that way they can always be available to interact with the company. The CHMP usually provides an opinion, some consent. Some of the members might disagree, might object, and this can happen with orphan drugs, so it would then be included in the conclusions. And they can also provide an opinion after the initial authorization. And this is important because if a drug is approved with a conditional approval for marketing, then the pharmaceutical company has to provide additional data, and sometimes this results in the withdrawal of the approval for marketing. So CHMP has to consider the risk-benefit ratio related to that drug. And this ratio depends on the disease and on therapeutic options. If there are no therapeutic options, then clearly the risk-benefit is important, and we have to accelerate the data evaluation process. The scientific advice is the first process. So the companies, the patient associations, academia can contact EMA for an informal discussion. What is the best route to follow in order to get an opinion or some advice on what I want to do? These preliminary discussions can result in the second step, which is either that of the scientific advice being given, the opinion, or an innovation meeting. In these two groups, they provide more detailed guidance in writing on the development plans, and they could also ask the company to submit an application for PRIME. The scientific advice is a bit more binding. It is a bit more structured than the ITF, the Technical Innovation Forum. So I would say that it provides more certainty to the business, whereas the ITF meeting is a meeting where experts sit around a table, and it is more informal in the end. But the purpose is the same. We want to facilitate the assessment, and we want to try to clarify the aspirations of the company, what data has been collected, and what the best endpoints or populations to be defined are. The next step, number 4, is that after the dossier, the company has completed its studies, they think everything went well, and therefore they submit their application for approval for marketing. And at the moment, it takes 210 days to complete the process for the CHMP, which is needed for an opinion, and then the European Commission can ratify it, publish it on the official gazette, and therefore grant final approval for marketing. So it is a lengthy process, but it's being revised. And this is due to the fact that they will reduce the number of committees, so the number of steps and the consultation procedure. Now, what about when a drug receives conditional approval? If the disease is seriously disabling or lethal, then approval can be granted on the basis of partial data so that patients can access it more swiftly. Earlier, it doesn't mean that the data are not good or they are terrible or that they're not complete, of course, and therefore provide some guarantee. But this is when we have reliable indications that the risk-benefit ratio is positive and that there is a likelihood that more complete data will come. And this is important. For example, if they approve a drug and a randomized study hasn't yet begun, then it's not ethical to enroll patients with a placebo because there's an authorized therapy already, and I cannot create another study with the same drug to see whether or not it works with the placebo. So a placebo study, whether it's the prolongation, the extension of an existing study, or whether it's new, well, we have to consider this. So we have this. It works pretty well, and we'll know more in a certain number of months or years. This is the other judgment, basically. We have to say that it is swiftly available, but the risk is that the data aren't yet complete, which is what we would prefer. So this condition is reviewed every year. Unlike with other approvals, every year they have to ask how the studies are going, safety, assessments. These are called specific obligations, and they are binding. They are absolutely required. It's an obligation. So this is a pragmatic approach because we want access, but we have to safeguard and protect the patient. So there are some actions which are mandatory, and the studies have to be feasible, as I've said. So for ethical reasons, you cannot enroll patients. If that happens, then the study isn't feasible, so there will be no data. They have to be well designed, and then we need scientific opinions on the design of the study. They don't necessarily have to be randomized. It could even be a register, for example. And now we have a sore spot. For the past few years, I've been working on the issue of reimbursements in Europe and the implementation of the new law, the HTA law. Payers don't like it when the data are incomplete, unfortunately. And I conducted a study which is now being published. Of the conditional approvals, only 25% of the approvals are granted reimbursement in Europe because the data aren't sufficient, and therefore many payers cannot decide on the economic value of the reimbursement, how much to reimburse, and that's a problem. So the participation of payers initially in the design of the studies is important. They have to participate, and maybe we'll discuss this afterwards. So what data can I expect and when? And maybe I'll be able to pay following a different procedure rather than the traditional ones, the conventional ones. So transparency of information sources. EMA tries to be as transparent as possible. Clearly, we cannot disclose information when the drug is being developed, but once once the opinion is approved, then we have a presentation for the public, a summary presentation. There's a link here that you can consult if you're curious. They publish their positive opinions, the negative ones, and nothing is kept concealed or hidden. So positive, negative, and information on the applications that are withdrawn by the company. Now, EPAR is a public evaluation report, and they're so difficult to read, 100 to 200 pages long. I've done this for a long time. It's like a detective story, a crime story. You go to the very end to see what the conclusion is. The last few chapters are the important ones. There's a lot of discussion at first, but then you can always go back to that. But it's the final part that is most important. So there's a summary report, which is easier for the public to read. In any case, this is available to everyone. So you'll see general information on the product, the information leaflet, the features of the product, and then the conditions for approval. This is for additional studies. Then we have the scientific discussion, which is the longest part of the document, and it's only in English. And then we have information on what is being requested, what further studies are being requested, in other words. I don't have a crystal ball. This is still in progress. There will be finalization, I think, in 2026, and it will come into force after 2 years. We have procedural elements, legal and economic elements. We want to stimulate, boost research in Europe, and we want to try to find a balance between the speed of access, the research and innovation dimension, and of course there has to be an economic return for the companies. So these are all elements that are being discussed. The EMA committees might be reduced. Instead of 5, there will be 2. So the orphan drug experts, for example, will be transferred to the other main committees, and we will try to reduce the assessment time by at least a month. There will be an electronic illustration information leaflet for quick and easy consultation. And we have to simplify the process for pediatric studies. We have to change the exclusivity period even for orphan drugs, and then the patient representatives are proposed in the committees. There was a huge discussion on who could vote and who shouldn't vote, so this is all being discussed at the moment. What is important now for the patients so that they can become part of this regulatory process? Well, we need contacts with patient organizations. We heard this in many presentations today. Not only Duchenne organizations, the umbrella organizations are very important in order to transfer the information and knowledge from one to another, because no one can do it all on their own. And then because it creates critical mass, and we could do some lobbying at the European Parliament. You should use the training sessions organized at EMA and by the patient organizations. There's a link there. And then you can comment on the guidelines being developed, not only for Duchenne. There are guidelines being developed which could be important for Duchenne patients, such as the ones on digital monitoring methods of movements, which are perhaps more complete. And you could try to contribute to the clinical trials, the design of the trials, and in scientific opinions, in fact, we involve patients, and then participation in the trials as well. Over time, all my colleagues have always wanted to involve patients, to engage these patients. You shouldn't feel any reluctance in asking questions. If you're going to a meeting, you can prepare for that. Ask anyone to help you. They will very easily help you. Prepare for these meetings, either to answer simple questions, ask simple questions, or even if you have the need to be accompanied to the meeting, how you can do that. You shouldn't be shy. You should just come forward and ask what you need. The second point is on the areas where patient contribution is important. Quality of life, definitely, because the physicians always need to have a better understanding of the actual experience of patients. Then we have to define an unmet need, and then, of course, major public health interest, and define the main parameters. What is important to know when using a drug, and more recently, digital technologies, so the usability of these technologies. So thank you again. I have one final slide with this sort of bibliography, things that you can read and consult if you're interested, and thank you very much to Parent Project and to all of you for your attention.
Grazie Francesca, probabilmente poi ritorniamo su alcuni.
Thank you very much, Francesca. I'm sure we'll go back to some of the points that you've raised. So, Fabio Manti. So we've had a lot from this long-standing EMA work, but my question now is about patients, their perspective. What are their expectations, Fabio? Up to you. But first of all, I wish to thank you very much. I'd like to thank the previous speaker, because I'm going to pick up on some of the things she has said to talk about this wide community that is Parent Project here in Italy. Well, first of all, the Parent Project, is not an association that is against scientific methods. We've always played a role in the different drug approval or non-approval, or approval in the US but not in Europe pathways. We've always been there. We've always tried to go into that. But having said that, at least for this disease, but maybe not only for this disease, an assessment that is merely based on cost-benefit ratios, when, for example, there's a limited number of patients, when, for example, there are different management approaches all through Italy, for example. Well, I believe that all of that can easily lead to an assessment that is not to be considered as actually valid for all the patients involved. So if this system is only based on this cost-benefit ratio issue, which we can fully understand, of course, well, then we believe that is simply not enough. So as Fernanda said yesterday, Parent Project as an association has been working on that MR reflection paper for quite some time already, because, we believe that once these data have a structure of their own, when it is possible to share the way one comes up with such data, that will certainly allow for all patients to be fully involved. And we believe this must be the case as soon as possible. As soon as possible, let me repeat that, because actually one day before our conference began, an article was published about me and Fernanda answering some of the reflection paper issues and questions. And the first comment I got through social networks was, whatever you're going to do, do it now, because there's no time. There's no more time. So time is an issue, We know, we are perfectly well aware of how difficult it can be to get people to agree, but when it comes to diseases like this, we can't wait, In these past few days, we've heard about several therapeutical strategies, and the risk we run is to find that even the most promising ones among them have been discontinued, which would be a pity. I mean, this is a lack of resources, and we simply cannot accept that. Another possible problem that we believe is a real problem in our community regards FDA approval pathways that may not coincide with European approval pathways. Well, once again, we can understand there are differences. However, different assessment criteria about treatments, for example, are a bit too much. I mean, patients may have participated in international multi-center trials, and then the drug is approved in the US, but not in Europe. I mean, that's really, really disturbing. And now I'll move to my conclusions, because Pat and Ramona will now, take the floor, possibly giving us some of the answers. So actually, on the conference inauguration day, the Italian National Drug Agency has given access to reimbursement for a given treatment, which was not the case in France. Actually, just one day before in France, that approval was not given. So I can understand the first 4 chapters may become centralized. However, maybe what is happening within the EU framework may not serve the purpose of an equal treatment. Thank you. Thank you very much, Fabio. Well, learning about a patient's perspective is very important, especially insofar as this has showed the differences between Europe and the US, where they seem to be more efficient. Well, actually, they do not have the same legislation, I might add. So in Europe, we might go towards a higher degree of harmonization, thereby allowing member states to have their own power, because they don't like, giving, out their power, say, to the European Commission. So in other words, we can't have a European reimbursement mechanism, at least for orphan drugs. We need a much more complex legislation. So the European Commission should, come into play. And now it is my pleasure to give the floor to Ramona, who will be telling us about the instruments that her organization is using in order to make the stakeholder dialogue easier. So companies, patients, regulatory agencies, I mean companies are important because they are the ones that produce what we'll then have to examine. So Ramona, you have the floor. Tell us about what's happening in the US and give us your own suggestions.
Allora, innanzitutto grazie mille Susanna per l'opportunità, Parent Project, per avermi invitato a discutere questo argomento molto molto importante.
This is a very important subject, and considering what we've just heard about the differences that are observed as to access to drugs in Europe, we realize that there are frustrations. This is a frustrating situation because of the differences in access. Now, we've got to consider that it's not that they're disregarding the importance of the disease or the patients, but it's a question of how scientific uncertainty is being managed and what regulatory tools there are in order to reduce scientific uncertainty, which ones are used. Now, a crucial issue is the endpoints, the surrogate endpoints in particular. When we speak of the approval of accelerated pathways in the United States, we always say that in the use, they use the surrogates, whereas in Europe, they don't to the same extent. Well, first of all, we have to describe some terms to understand the difference. The validation of a biomarker as surrogate, and which can also be used in European states, and which is different from the ones that can be used in the United States as reasonably likely surrogates. So the biomarker is considered an element, and on the basis of biological and clinical characteristics that have to be coherent, they say that it is reasonably likely that there will be an impact on the clinical benefit, but it's not a validated measure yet, you see, for that biomarker in regulatory terms. So they're using a tool here which is more flexible if there's an accelerated pathway, for example, in the United States. And this is where we see the difference between this and the measures that are used by EMA. The validated surrogate endpoint can be used in any case, but there's always more attention, more focus on the instrument through which we have to determine clinical benefits. In other words, the functional endpoints. So we have to understand the difference in these terms and in the structures, as it were, that are being used in order to generate evidence in support of these elements. This is all very important. And once we realize what the differences are, we see that there are multiple events, and the approval of a drug with the accelerated procedure. Okay, maybe you have a conditional approval in EMA, but in any case, the evidence used is different. That doesn't mean that it doesn't pass the evaluation standards for that drug. It just means that we have to be better prepared, because the evidence that we provide in support of the information as to clinical benefits, the information, the evidence have to be supported by a validation through these tools that we use in order to determine the efficacy of a drug in trials. And it isn't only a question of using a biomarker, for example. We have to validate it, we have to characterize it for what we call context of use. We have to specify how it'll be used, and we have to debate the adequacy with regulators of that use as soon as possible, and not later when the study is already over and we haven't yet had a discussion on how it can be used and how we observe the data. So we have to ask whether the biomarker works, but then we have to ask, does the biomarker provide us with the clinical benefits information? So we need evidence in order to answer those questions. I think that this would be a better way to achieve a quicker, a swifter result. So characterization and validation of biomarkers are not easy processes. They're not swift processes at all. That's a problem. So we've done something thanks to Parent Project Muscular Dystrophy in the United States. We launched an initiative for a competition for a public-private entity, a Duchenne consortium, CPAT, which I manage, which I run. And there are initiatives whereby all the stakeholders can participate in the development of a drug in order to speed up the process for harmonization in data collection, standardization of how the data are handled once they're collected, but then they're integrated, pooled, to create that briefing package which is sent to the regulators. And then this can never be a process carried out by a single sponsor, because the procedure is lengthy and we don't always immediately see the effect on cost-benefit. So we have to share the process. We want to increase the collection of data. We can use studies even from the real world here. So we have to collect this real-world data on the experience of patients, and we have to integrate the data on natural history appropriately and in a standardized way. And that way we can use the data better in our conversations with regulators. This is key, because that way we can be swifter in determining the adequacy of the data for the approval of a drug. So again, we have to understand these dynamics on the timing and on how we can integrate the data on patient experience and even define the burden. We know that we use the reasonably like surrogate for the regulation of dystrophin, for example, but we also know that there are differences as to how the data are collected. After so many years, still, after the biomarker was established, why not be better prepared early on, you see? So this group of stakeholders is important. They are the experts on the disease and on the clinical process. And they should all come together and determine what tools we have and what we accept as a community and in what phase of the clinical development. Because we could propose that a biomarker be used in phase 1 or phase 2 of the clinical trial, but maybe not in phase 3. Or we could propose that a biomarker be used in the early phases of the disease, but not in the non-ambulating phases, because it wouldn't be appropriate in that stage of the disease. So it is important to have these conversations even before we design the study. I think it is essential. And that way we are ready to provide the evidence which will then support with greater certainty the approval of a drug. Thank you.
Excellent. Grazie Ramona. E allora io
Thank you very much. Thank you, Ramona. And now I'm going to ask Pat about the action that you believe can be relevant and effective, and that you have already, implemented in the U.S. as a Parent Project Muscular Dystrophy, and that could be inspirational for us, for all European associations. Give us a couple of actions that have been truly effective, according to you, Pat.
Yes, thank you so much. Thank you so much for the opportunity to speak. PPMD is an organization that now has been 30 years in its initiative until today. And as we first started the organization, we certainly were trying to invest in research. We also worked in legislation, because in the United States, getting some legislation in place for us was very important, because we knew that as a rare disease, we could not make the money or raise the money necessary for incentivizing industry to know that the disease was well characterized and they could begin to think about therapy development. So we were lucky enough to think about some legislation, and we were also lucky enough to find champions in our Congress that would advance that legislation. The legislation was called the Muscular Dystrophy Care Act, signed into law in 2001, and to date, $900 million investment on our government for Duchenne muscular dystrophy specific and greater investment across. So it's much more than almost $2 billion in neuromuscular disease. So that's sort of the framework. As we saw industry come on board, we were very interested in understanding, how do these approvals happen? How do we get drugs over the line so that patients can receive them? So we long ago decided we would have a forum and invite the FDA in to that forum. So we did that. It was called the Duchenne Forum. We had representation from all sorts of across the age and lifespan of patients. We had patients and we had family members talk to the FDA about their lived experience. Here's how it feels to live with Duchenne muscular dystrophy, both from the patient side of view and the family side of view. So that was set the framework. Now, just to talk about our FDA, it works quite differently, although there are threads that are very similar in terms of the processes. We have the law that regulates our FDA is called PDUFA, Prescription Drug User Fee Act. And that's negotiated every several years. It comes out now again to be negotiated in 2027. This is the framework of the law that the FDA operates under. It is not done in isolation. Patient groups are involved in that. We are involved in creating ideas and thinking about ways to facilitate and accelerate therapy development. So our voice is there. We also have this belief that we, as a community, need to be represented across the community, not just by several members, not just by me, but by all of our community's voice needs to be heard. So the FDA then, in the legislation of PDUFA, then there are two divisions that work with us. One is the Center for Drugs, which are drugs. This is what we would consider downstream or the drugs that are being in development. And then there's the Center for Biologics, which is gene and cell therapy. So those are over there, and those are two different divisions that review separately. So in our view, how do you get representation? Remember, we did a forum, and in the legislation then, we and other rare disease really pursued a framework called the Patient-Focused Drug Development, or because we use acronyms all the time, it's called PFDD. And in that, there were advantages and opportunities, and that law still stands. One of them is a listening session. And if there is a disease, a rare disease that the FDA is not familiar with, or even familiar with to some degree, that the patient community doesn't feel they know enough or understand enough, you can do a listening session. This requires a submission of an application, a lot of back and forth. We recently completed a listening session on Becker muscular dystrophy as distinct from Duchenne, because we felt that the FDA needed to understand the distinction. So in that session, we had about 8 different patients with Duchenne. Again, That's a listening session. That's one opportunity for a collective to interact with FDA. The other ways we interact with FDA are several that we've done over the years. One is doing preference studies to understand from our community in a very rigorous way, what are your priorities? How do you think about this? What's important to you? So that data is done with social scientists, so it's done in a very rigorous way so that we can provide that to the FDA. We've done many preference studies, to include one on gene therapy, so we know those preferences. And we did one as gene therapy studies started to understand the benefit risk. How much risk will you take and how much benefit do you expect? So what will you give to get some benefit? Again, providing that to FDA. Once the gene therapy studies started and we learned more, we saw some risk, we did it again. We wanted to know, has your judgment of benefit risk changed? So again, we are really trying to understand, as knowledge evolves, has that benefit risk evaluation changed in any way, so that we're updating the FDA about our community's understanding of benefit and risk. What will they spend? What will they take? And this last one included death. What risk will you take, even if there's a risk of death, to the benefit you expect? The other idea that we had was, because now we had many companies coming in and still do, which we're very thrilled about. We felt that the FDA needed a playbook, a guide about what do we know now, from diagnosis through natural history, through therapies, through cardiac, through outcome measures. What do we want you to know? So we gathered our community one more time. We continually gather them repeatedly, and we wrote draft guidance for the FDA. This draft guidance consisted of about 150 people, clinicians, people from the community who wanted to participate, and industry, so that we had this collective voice again. Here's your playbook. We did that in 2014. We updated it and published it in 2023. We see it as a living document, so that now we have newborn screening in the United States. It was added to RUSP on December 16th. So now we're going to get babies. So now we're going to probably update that guidance again in a few years as we understand getting these infants on board. So I think from my perspective, the voice of the patient can't be one or two voices. It has to be a collective voice, so that we're representative, so that the FDA understands we want safe and effective drugs. We weigh that safety and effectiveness under a disease that's progressive, that boys, young men, and some women lose muscle every single day. So we're not asking FDA to compromise their standards. We're asking FDA to develop a framework that is different from a general disease where they have 1 million people with high blood pressure. You can't cookie cutter that into a rare disease. So we're continuously working with the FDA. More recently, they have really announced a framework called plausible mechanism. Now, to be fair, we don't know what the bones of that's going to be, but the plausible mechanism says if it's a biologically plausible mechanism, you can do a one single arm trial that is very rigorous and maybe get an approval if all of the data lines up. So I think these are ways in which we as a collective community move the FDA further. And I will say, because some of these processes are very similar, I would hope there was one day harmonization. We have 8 approvals in the US, 1 pending. We have 2 submissions expected before the end of the year. On antisense oligonucleotide, there will be a day. And then for a community, we can figure out how to combine them in a safe and effective way. What patient, what drugs, in what way to halt disease progression. Last, I'll say that we're in another preference study, and this time to prove to the FDA that we're not looking, we don't expect or necessarily anticipate an improvement in the North Star or the time to stand or the 4-stair climb. What we want is, if this individual is stable, that's sufficient for approval. Because as we see in this disease, because it's progressive, in a 12-month study, we're often not able to see the effect of the drug as much to improve the North Star and such. And studies, as you know, are going to 18 months. 18 months in the life of progressive disease is really a long time. So how can we figure out better with surrogates, with stability, that this drug is deserving approval? Recognizing that we don't want any compromise of standards, but we have to understand that these urgent need needs to be met for all patients.
Thank you very much, Pat. Was very clear.
Grazie davvero, Pat, è stato tutto chiarissimo.
You have noticed that, I'm sorry, I shift to English. So, allora, quindi...
Okay, thank you very much, Pat. Let me briefly sum up 3 important points. We all agree that laws are different, the laws in the US and Europe, and we also agree that the FDA organizes things differently. And Pat has underscored the fact that Parent Project has managed to conduct preference studies for examples, and the results were submitted to the regulators. Parent Project has managed to do that, but also to policymakers, to lawmakers. They've also submitted this data to them. So I think that patients have to be well organized in their work. They have to do this in a regular fashion. They have to have a structure for the activities that are performed. And this must be brought to the attention not only of FDA, they have the necessary instruments to deal with this, but also to the Congress, to the lawmakers, to the policymakers, because that way their lawyers can turn all that into new laws. Now, let me go back to Francesca. In Europe, how can we implement 1 or 2 of these examples described by Pat? We've already got some of these elements. For example, you were describing the biomarkers. If a biomarker is likely or plausible, and if it is correlated with a clinical outcome, well, in the past, we've taken decisions on this with the FDA, joint decisions. So these are processes that the associations can support. We have a dialogue with FDA. 15 years ago, I created this parallel advice committee with the FDA. It isn't often used, not with the current administration in the United States for obvious reasons and problems, but it does exist. And as I said, there's the will to do this. And if patients have biomarkers and they want them to be approved, because these clinical studies, the multinational studies, have to be conducted in a harmonized fashion. So this is something that can definitely be done. And I like what you said. It isn't only ethical to conduct a study against a placebo, with a placebo, if a medicine exists, but we don't want to conduct a study if it is poorly designed, because I'm wasting patients' time. I'm wasting therapeutic opportunities with patients. So we have to be harmonized in these criteria. I think this is very, very important. I would also add that we need to eliminate any gaps. If we have a pharmaceutical company, for example, that is setting up a development project, then we have to reduce any gaps at the very start. The gaps between the FDA perspective and the EMA perspective. How can that be done? Well, the company can early on use protocol assistance, which would be free scientific advice. It becomes free because it's being used for an orphan drug. So we have all these facilitations, these instruments, you see, but all the stakeholders have to agree. They have to be, on the same page. Now, each might have some limits, of course. If there's a drug that's already at the end of phase 2, and if it's begun phase 3 and FDA has validated the design of the phase 3 study, then we go to EMA for scientific advice. Well, probably there will be difficulties there because they might not have the same idea. But if we go early on at the end of phase 1, in other words, then probably we'll manage to build up a regulatory process which is confluent, which is consistent on both sides. In Europe, we have some wonderful mechanisms. A drug can be approved even with one single clinical trial. If it is consistent with the non-clinical previous development work done, and if the data, if the evidence is hard. So we have these tools. It's just that we don't often have agreement among all the stakeholders. So let me give the floor back to Ramon. With regard to the pathways for new methodologies, novel methodologies, qualification pathway, basically, this is similar to some of the pilot programs that the FDA has worked on recently. Rare disease, for example, and model-informed drug development, which is a pilot program that is looking at the models for disease progression from a quantitative point of view using special endpoints. And this is a success story that we have. There was a support letter from the first clinical trial simulation tool for Duchenne, which we developed in this pre-competitive initiative. So the support letter was provided by the EMA, and in that case, they were pioneering this work on this innovative tool. Now, what happens is that it requires the cooperation of multiple stakeholders, and it requires more data than the data that an individual sponsor might be able to provide to the agency. So, the disease progression model was developed using 15 data sets coming from different studies of different natures. So not simply from one study, but many, many studies that were then integrated using the same standardized language, which was then used for the advancement of these innovative solutions. This is something which is still being reviewed by the FDA, but EMA provided that support letter, and in doing so, they encouraged them to use those tools. So you see, the researcher communities believe that we can use the biomarkers, we can increase the evidence, and in doing that, we can increase the data that are needed in order to support the evidence, and so that we can have confirmation on that data. Thank you, Ramona. This brings us back to data again. Data are important, they must be standardized, they must be collected according to certain modalities, and they must be predefined early on in terms of the use of how the data will be used. I keep going back to this issue of data because in the past 15 years, I've been focusing extensively on data production, but they need to have a regulatory validity. So it's true for biomarkers, but also for clinics, for registers, for data that are directly generated by the patients. So now let me go back to the role of patients. Yesterday, Fernanda told us about the first output of Parent Project for EMA. It was a comment on the guidance of data generation. This is extremely important, and I hope that this is just the beginning of a success story, where patients are more capable of generating important data, such as the patient reporting outcome. There are questionnaires that are produced so that patients can fill them in without anyone helping. These data are becoming more and more important in the regulatory process, more important than what they were 15 years ago. So this is another success story. The patients have an ever-increasing voice in this regulatory process. Francesca, over to you.
A
very short comment on this point. I mentioned the study on limited reimbursements after approval, and there is a difference in the countries, and this also depends on the economic resources of the individual countries. But there is something that we saw throughout the study, and that is the importance attached to the quality of life by the HTA. So this standardization and data collection and the experience in drug use, well, EMA provides a superficial assessment of this. Instead, the HTA has a more in-depth assessment. So common language can result in massive data which can be better used. Thank you, Francesca. And this takes us back to the difficulty in Europe after a positive approval of the CHMP and the opinion of the committee, of the Commission. Well, there's something that is unknown for the Italian Pharmaceuticals Agency or the French agency, for example, or others. We don't know about the timing there, you see. So this is what we have to focus on, this part of the process. So EMA has worked extensively in order to standardize, because we used to have 27 completely different approaches in European countries. NICE in the UK tried to do something. It is very difficult, however, to negotiate with NICE, with this agency, because I remember in the beginning that it was a nightmare. So this part of the process, I think, needs more focus. We need to change something, do something new and different. This year, we invited a representative of the Italian Pharmaceuticals Agency, AIFA, because they're the ones who deal with this final part of the process. But they weren't able to attend this year, and we do hope that next year they will participate in this part of the debate. That way, they'll be able to tell us a bit more about what's going on. So the change in the laws on reimbursements, they're trying to speed up the approval and evaluation of the value of the drug. So maybe it's a bit early to expect this year, but it might come next year. There will be a bit more experience and more confidence, as it were, in the process. Okay, I think that we're on schedule. We have 10 more minutes, maybe, do we? Do we have 10 more minutes? 8. I will try to summarize, therefore. Pat, you spoke once. Would you like to convey a special message? And then I will try to sum up what everybody has said. So do you have a key message that you would like to convey at this point of our discussion?
I think my only key message would be that I think the voice of the patient is critically important. I think it can't be a single or a double or a triple representative. I think the voice, the collective voice through preference studies, the collective voice through meeting with EMA under whatever frameworks they have developed, to sit in front of them and teach them about living with. Because while I agree that data is critically important, I think the knowledge of what living with a given disease is and feels like is really essential to have in their mind as they're reviewing the data, because it can't just be data. We aren't just data. We are human beings living with a disease, and I think we need to be equally represented so that they have a clear understanding of value and our value from our perspective.
Grazie Pat. Allora io ho preparato 2 slide per riassumere.
I have 2 slides just to recap.
Grazie. Allora, il primo punto è
So, first of all, patients want to, but also can actually participate in a more active way to generating significant data, and that may represent an actual benefit. You know, biomarkers can be okay, but we need them to be beneficial, and their contribution is of paramount importance when it comes to rare disease, where patients are more important than in the framework of other diseases. So there's a lot more we can do about it. In Europe, EMA, as we've learned from Francesca, together with the national agencies, the National Agency Network, well, they are both open to discussion through several mechanisms, hopefully able to enhance a pathway that is effective from a methodological viewpoint, certainly for the sake of the final approval, but also for one that may cover as many patients as possible, so that if a drug is approved only in Belgium, I mean, that would not be enough, quite frankly. That's not what we have in mind. And on the other hand, the assessment criteria of files, as we've learned from Fabio, may not be, easily interpreted. Well, actually, the point of these files is that they do not tell the whole story. Let us put it that way. They seem to lack some parts, such as, the outcomes. So this is actually one of the differences that are obvious, between the EU and the US. So this is my last slide. We already have some regulatory mechanisms enhancing patients' involvement in Europe at different stages of the clinical development, and even when the assessment time comes, because patients are represented in each one of these committees. I don't know whether that has been clear enough. I mean, within EMA, patients are represented, and their representatives can actually take the floor and have a say in almost, at almost all stages of the process. And now, companies, they should be engaged in a dialogue with regulatory agencies since the beginning, because they need to comply with the EU legislation. And there's something more I may say here. Actually, the chief medical officer gave us food for thought a couple of months ago. But I mean, unless they come to see us, we can't let them know what we actually want. I mean, if it's at the end of phase 1 or beginning of phase 2 and nobody has come to see us, we can't really let our, thinking out. And then, as you've just heard, maybe more clinical trials should be carried out in Europe. Last year, I was in a webinar with one of the companies working on gene therapy, and at the end of the webinar, I asked about studies being carried out in Europe, and I mean, I seem to have got no answer. So there's room for improvement here, I believe. So treatments, effective and approved treatments should be for all, but there's still one problem, namely when the health technology assessment comes and when the price is decided, because it must be adjusted to the single country's resources. That's different, between Europe and the US, where they have a completely different mechanism. And I would really recap it all by saying that we need stakeholders to agree to a higher degree. Stakeholders are companies, academia, patients, and regulatory agencies. Academia has not been mentioned so far, but we might want to include, that category too. So if you agree with this take-home message, let us all work so as to have a higher degree of agreement among stakeholders in methods, objectives, and action. Thank you all. I'd like to thank Parent Project for having us here. That was the first time that a regulatory roundtable table has been held within your conference, so hopefully this will still be the case in the future. And I would certainly like to wish you all the best. When I say you, I mean all those trials that are now being developed. Thank you.
Allora eccoci, siamo arrivati alla fine della nostra 3 giorni.
We've been organizing this conference for the last 10 months or so, and then we are at the end of the conference itself. Please pay attention for just a few more minutes. During the opening ceremony, there was here an actor voicing the stories of some DMD boys. However, in this community, there are also other people, other minds, all those who work with BMD, I mean patients, families, siblings.
La nostra associazione è nata da tante strade, percorsi, traiettorie, come i viaggi in camper di Filippo che
Our association has gone through a lot. Filippo started by actually going to see the families where the diagnosis had just arrived. So we seem to live in an extremely challenging time because now we are supposed to change the way in which the so-called able-bodied look at the disabled people. We don't want to have any compassionate approach. We want something else. So if you're here today, it's because we want to close our conference by asking Michele Di Silvestro, Celebrin, Marco, and Matteo Massaiolo. We are going to ask them to come to the podium. They are going to tell us about their roots that start from a long time ago. We don't know where they're going to go, but we know where they met. Thank you.
Quando ricevi una diagnosi, il
When you get a diagnosis, time stops. You are in a hospital room. We were at the Policlinico, and you feel like first you were stronger, but then you're not strong any longer. You feel lonely. So Parent Project has counted for us as a real embrace. I will never forget the first conference. We were scared, we were quite afraid to enter the room. We didn't know what would soon be the case. But then Tiziana came to see us, and before that we had just exchanged some emails. So she says, "Hi, Michele, hi, Elena, welcome." And then something changed. We felt like we were being recognized, and we did not feel lonely again. So we needed a community to be started, sharing the hard labor, and we owe this to Parent Project that has given us the strength that we had lost at the hospital. We know it's a long way, but it's certainly less tiring, and it doesn't go along a linear curve, but it's not a closed circuit either. It's something that helps us move forward. Parent Project for me is basically a large family where I have managed to meet many people, patients, professionals, ordinary people who all share the same enthusiasm in setting up an active community of DMD and BMD patients with a holistic approach. I had, already learned about Parent Project, but I got closer during the experimental trial that took place in Milan in 2019. I already knew the psychologist who was there assisting us, and then I realized I was to take a more active part in the Parent Project activities. I came to know more and more people also with BMD. So in 2025, I became an active member of the BMD coffee community, whereby all BMD patients hopefully are gathered together. BMD is a community that is a line moving upwards, and we seem to be going forward as years go by. So we believe that we are a part and parcel of this group. We share diagnosis. We also share our lived experience, our needs, and our wishes, but also thoughts and emotions. Our hard time and our assets. We feel like we are all important because the community sees us as persons first and foremost. Thank you.
Allora, Parent Project è
Parent Project is one of the most important things in my life because in this society there are many people who appreciate me and who have esteem for me for what I am, and my disease isn't stronger than me. I can beat it, and it has taught me that there are many things I can do with the Duchenne, and my physical disability would not stop me. It would help me overcome my shyness. When I was only 6, I had to speak before many people, and I learned to no longer be afraid and to feel more confident. In 2019, I participated in the Parent Project campaign, and I realized that I could help and contribute to the association, and that if we all work together, we can be successful. If I were to describe my life as a route, as a trajectory, I would define it as a multicolored wavy curve, not straight and direct, because I think that my story has been positive, and I want to say a big thank you to Parent Project. Parent Project is a lot more than just an association. It is a point of reference for me, a beacon. It is a home. It is a wonderful family that takes me in, and I feel part of something, therefore. And as a sibling, I can express my voice. I can be seen now. I can be recognized and listened to. Now, if you are growing up with somebody with Duchenne, you're always in the background. You're there, but you're invisible. To be a sibling has meant to have to grow up very quickly, and I quickly learned what it means to shoulder a responsibility and to live with the fear, with questions, and with silence. Since I've known Parent Project, my life has changed. I can understand my personal needs and distinguish them from what it means to live in a family that has to take care of somebody with Duchenne. I realize that I have a space and that I can also be listened to. I have this right, and that doesn't mean that you must love the other any less. I am here now to show my gratitude. In the past 10 years, the association has done a lot for siblings as well. We weren't there at first. Actually, we were there, but we didn't have our own space. Whereas today, we have parallel sessions, and we participate in those, and we have spaces where we can share and where we can be understood, where we can be accepted and welcomed. I am here to bear witness to the fact that a sister or a brother can also be an active part of a life process and of personal growth that involves us all. Today, thanks to research, to the will and the commitment of the entire community, we can think of a better future. And the trajectory is like a circle. This route is a circle, which means that we can attach great meaning and significance to research, to cure, and to our daily engagement. But that's not an end. It's an identity that is being created, which can be recognized, which is solid, and which can become a resource for all of society. And today, to be here means something very simple, but fundamental. That's what we are. Yes, we siblings are here as well, and we want to keep growing together.
Ora vorrei chiedere a tutti I componenti dello staff.
I would now like to ask all the staff members of Parent Project to please come up to the stage right next to me, and all our friends who will stay here with us. And as you come up, I can tell you what their names are. I'm sure you know them all. Here we have Marica Pugliese, Gaia Lucenti, Ilaria Zito, Emanuela Giulitti, Francesca Mattei,
Sara Massimi, Laura Grasselli, Fabiana Boccia, Fernanda De Angelis, Mirko Natili, Emilio Lodise, Francesca Buontempi, Elena Poletti, Eugenio Baroncelli, Fabio Amanti, Aurora Giacalone, Lucilla Patrizi, Valeria Schiesaro, Sara Billai, Anna Petruzza, Giada Perinel, Cristina Bella, Leonardo Ruffolo, Giuseppe Giardina, Marica Cescato, Alessia Ministeri, Nicoletta Carfì e Carmen Rocca Sileo. Eccoci qua. Questi giorni una canzone prevista
we were going to play a song, and then we'll be inviting you to the next major event.
L'anno prossimo per festeggiare 30 anni di Parent Project tutti insieme a febbraio 2027. Grazie a tutti, grazie.
and grace. And I thought, what could I